constrain the COVID situation in India. But it's getting better, and hopefully soon we are hoping for the vaccine also, like in the news.
Absolutely, absolutely. And has compliance with a lot of those measures been high? In Australia, we have anti-vaccination as a bit of a thing in itself, and then telling Australians to sort of stay home or not to meet and go out has been challenging.
Yes, so compliance is also very high. Most of the marriages happened during the COVID-19 in a solitary. That's a big compliance, because in India the wedding is like many days event, so it's not a one day event. And in India, in a single wedding, we used to call around 200 to 1,000 people. So we can see that in the weddings also, that only a few family members have gathered and they just got married. So it's a big compliance towards the COVID-19. This is the best example I can give you.
Absolutely, yeah.
Yes, so the compliance has also been there. We have seen that people are complying to being in the quarantine if they are getting the positive of COVID. So yes.
Great. Should I just try and share my screen here?
Josh, wait some time. Let me admit all delegates.
Okay. It does come up when I try to share screen that host has disabled attendee screen sharing.
Yeah, just a moment. I will share some things here.
Okay.
మొత్తం కనపడదా ఓపెన్ చేసి పెట్టుకోవాలా ఇమేజ్ షేర్ చేయాలంటే వర్డ్ డాక్యుమెంట్ ఓపెన్ చేసేసి స్క్రీన్ షేర్ చేసి Thank you very much. Ready on. Lola. My word document. Word document. Yeah. Yeah. Keep it a bit. Keep it in WhatsApp. Keep it. WhatsApp. Keep it. Keep it. Yeah, Joshua.
Yes.
Yeah, just a minute. The most of delegates are joining.
Okay.
So before that, I'm very thankful to you
No.
by accepting our invitation through ISPAR ANU student chapter and ISPAR India Amravati regional chapter.
My pleasure.
And our institute, Chalapati Institute of Pharmaceutical Sciences. So let's wait for some time. The most of delegates are joining the session.
No worries at all.
Before that, I will read your profile and I read my college profile, and then we'll continue the session.
Sounds good. I'm just having trouble sharing the slides on this
Yeah,
end.
you can share. You can share later when I will tell you when to share the screen.
Perfect. Perfect.
Yeah. ఇది వస్తుందా స్క్రీన్ షేర్ స్క్రీన్ వస్తుందా వాళ్ళ ఇమేజ్ వస్తుందా A very good morning to one and all. I am Dr. Anvi Ramarao, Associate Professor, Head of the Department of Pharmaceutics, Telapati University of Pharmaceutical Sciences. First and foremost, I thank our dynamic and visionary principal, Professor Ramarao Nadenla, and management Sri Y.V. Anjaneyulu Garu to provide us such a virtual facility to conduct international virtual conference on pharmacoeconomics and outcome research. I cordially welcome you all on account of Telapati University of Pharmaceutical Sciences to international virtual conference. Dr. K. Nagasri, the President ISPAR ANU Student Chapter, and Professor Ramarao Nadenla, President ISPAR India Amravati Regional Chapter, jointly organizing virtual conference on pharmacoeconomics and outcome research. The pharmacoeconomics and outcome research, health economics and outcome research, and HTA, health technology assessment, are growing area in healthcare sector. As per my knowledge, by observing international scenario, these areas can impact wide range on healthcare system, also helps in molding most PharmD healthcare careers. I hope all PharmD, B.Pharm, M.Pharm students and healthcare professionals can utilize this opportunity and feel free to interact with the renowned speakers. I'm requesting all delegates who have joined the session, we'll send the feedback to you, your respective mail ID who have registered with our registration link. Once if you send the feedback link to us, you'll receive the e-certificate to your respective mail ID. Delegates who are not able to join the session, please join the session by YouTube live link, which is there in your email ID. Without wasting much time, I welcome Nagasri to read the profile of today's guest speaker, Professor Joshua Byrnes from Australia. Nagasri, please read the profile of Professor Joshua Byrnes, Griffith University.
Very good morning, everyone. This is Nagasri, the president of ISPAR ANU Student Chapter. It's a great honor for me to read the profile of Professor Joshua Byrnes, the assistant professor from Griffith University Center for Applied Health Economics, Brisbane, Australia. Sir has worked as an academic and consulting health economist since 2011 after he was awarded his PhD in health economics from the University of New South Wales. Sir is the current Australian president of the International Society for Pharmacoeconomics and Outcomes Research, the largest health economics and outcomes research organization globally. Sir has significantly impacted and influenced policy, practice, and funding decisions in the Australian health system. Sir is the member of Epic Health Systems since 2018. Sir also a member of Healthcare Practice and Survivorship from 2018. Thank you.
I'm just having a bit of trouble on this end sharing my slides. Still just getting a bit of a message saying that it's not enabled.
Joshua has requested earlier so that you can share the slide if possible, and you are on mute. If you are saying something, we are not hearing.
Okay, madam.
So Josh has requested, he is having some technicality to share the slides. So Rao, if you could please share the slides so that he can start his.
Yeah. Josh, are you sharing PPT?
When I click on share screen, I get a message saying that the host has
Just before that, you open the PPT, the PowerPoint, then go to share screen, then you can find your PPT.
So when I click on share screen, that's when I get the message saying that the host has disabled screen sharing.
Now you can try.
There we go. Fantastic.
Now you can try. I think there is permission required. Yeah, it has come.
Excellent.
Yes.
Well, wonderful. Good morning, everybody.
Yeah, please open your video. I think I'm unable to see you.
As well, can do. There we go. Wonderful. Good morning, everybody. My name is Josh.
Yeah, please share your video. I think we are not able to see your face.
I've got screen sharing video
Rao, I can see him.
He's come. Okay, then it's fine.
Okay. Wonderful. New technology and new era.
Yeah, the technology is making it very difficult. And it is very convenient also to welcome you like people from globally to India to share your knowledge.
No, my pleasure. And thank you very much to the IVCPEOR chapters for the invitation today. I'm Josh Burns, the Director for the Centre for Applied Health Economics in the School of Medicine at Griffith University and the current President for IVCPEOR Australia chapter. Today, I've got the very fortunate honour of opening today's session, and with the title Designing, Performing and Evaluation of Pharmacoeconomics and Outcomes Research. Briefly, what I'll try and cover in the time that we have today is to go through an economic evaluation in relatively brief terms, looking at the components, the relative components that we include in an economic evaluation, being outcomes, costs, and our primary result, an incremental cost effectiveness ratio. And then I'll hope to provide a few insights regarding the design of an economic evaluation study, performing an economic evaluation study, and importantly, at the end, evaluating. So the importance of economics in priority setting, especially in health priority setting, the fundamental truth that we're faced with is that available health budgets do not permit all people in all circumstances to access all available health care. The issue then really becomes on how to deploy these resources in order to maximize the potential benefit. The goal of health economics is to work out the costs and benefits of technologies, and technologies here being the broadest definition with regards to the new application of knowledge. And this can include drugs, pharmaceuticals, but also procedures, devices, services, and processes, so how things are organized and structured. And we do this in a way to help inform difficult decisions that have to be made. Health economics seeks to value the outcomes and maximize its benefit and relative to its cost. So fundamentally, it regards to efficiency. We do this in a systematic and quantitative approach so that we can evaluate decisions between multiple alternatives, recognizing the uncertainty inherent in there. For me, as a health economist, I always think that ultimately it's about efficiency, but the true cost here of inefficiency is the patients not treated, the lives not saved, or the years lived in poor health that didn't otherwise have to be, were it not that we were making the right choices and maximizing our opportunities. So we can take a step back and start with what is health economics. And we can consider economics to be the study of behavior of people with choices. And although it's tempting to sometimes think that it's just about cutting costs, it's not. And nor is it just simply about adding up costs. It's really to provide an approach to rational decision making, focusing on preferences, incentives, the opportunity cost, what else could we have done, and looking at the change at the margin. So our starting point for health economics really takes into consideration that resources are limited, whether it be money or staff capacity, staff knowledge, energy, effort. There are virtually unlimited uses of those resources to put into prevention, treatment, hospitals, more beds, high-cost drugs, new technologies, other technologies. And therefore, healthcare really is an economic good. So it's scarce relative to our want for it, which means that we have to make choices about the way healthcare is funded, produced, and distributed. The tool that we sort of use as health economists then is economic evaluation to try and ensure that we're making as best a decision as possible to try and maximize our benefits, our gains. Perhaps the nicest quote from a textbook by Drummond back in 2005, an economic evaluation at its heart is a comparative analysis of alternative courses of action, considering both their costs and consequences. I think regardless, at least for me, regardless of how we go on to perhaps mathematically model this, I always in my mindset have this nice tree diagram. We have to make a choice between program A and program B, or drug A or drug B. Each have got costs associated with them, and they will have consequences. The paths that we take regarding implementing one or the other, and then I like this diagram just because it really shows, I guess, if you like, this kind of alternatives that we must consider and their long-term or subsequent sort of events that need to be considered in our decision making. So why is economic evaluation important? As I said, to recap, choices must be made. Regardless of whether or not we necessarily think that they're going to be made or want to perhaps suggest that we can avoid choices, the choices to undertake an economic evaluation, the choice to proceed or not to proceed will be made. What we're trying to do with an economic evaluation is to provide an organized consideration of the factors involved. We take into consideration that it's often not possible to truly understand all the relevant alternatives, what goes in, the factors, the contributors, all the outcomes and consequences without a systematic approach to it. And finally, we need to measure both costs and outputs if we're to judge whether funds are used efficiently and represent the most value for money. So within an economic evaluation, like any sort of research or any other sort of approach that we may have, it starts with a question. And in an economic evaluation, we build essentially from an evidence-based medicine sort of approach where we consider our options, and typically within regards to a PICO, or the population, intervention, comparison, and outcomes. But within an economic evaluation, we build further and expand upon this because we're mindful of the perspective and clear thereof. Economic evaluations are a decision-making aid, and therefore we must be clear in terms of whose decision it is that we're evaluating and who are we assisting. This can be an alternative, can be from a range of perspectives. It can be from the payer, who is it that's funding the investment of the new technology, whether it be private insurance or a social insurance scheme like Medicare or Medicaid, or in Australia, Medicare and the Australian hospital arrangements. It can also be the individual if it's an out-of-pocket cost expenditure. We can look a little broader to consider health sector, so not just a single institution or a single setting, but rather across settings, so involving community and public health sort of areas and facilities, as well as hospital sort of related costs and consequences. Or we can take it from the most broader sort of societal perspective, where we may consider benefits not just with regards to health, for example, but also in terms of education, attainment, employment, or even potentially crime, especially if we're thinking things around, for example, opioid abuse or treatment of opioid abuse. In an economic evaluation, time frame for our analysis is one that's long enough to capture all relevant benefits and costs. And this is often one of the largest clashes between the economic evaluation and the data that we have available. Our analytical time horizon for an economic evaluation must consider all subsequent and associated and relevant consequences, which is often a longer period which is observed in a trial or in other settings. So we can break these through and go through these a bit more in detail in terms of how we frame up our question, starting with population. So we need to be able to define and describe our population with regards to the characteristics of the population of interest. So we need to be inclusive of patient disease or the condition, but potentially also specific demographics or line of treatment. Here is an example from the Pharmaceutical Benefits Advisory Committee, the committee in Australia which determines reimbursement from government funding for new listings of pharmaceuticals. And this is on a document that's available on the internet. This is a submission and a decision with regards to cannabidiol to treat seizures associated with Lennox-Gastaut syndrome or Dravet syndrome. And within these public summary documents, they always provide a nice P-code table. And so I'm just using this as an example in terms of how we may be able to describe our population for our consideration. In this document, they describe the population as patients of 2 years of age and older, so demographic characteristics, seizures associated with Lennox-Gastaut syndrome or Dravet syndrome. So here we have our disease and condition. And although not in the P-code table in the document, further in that document, we also find that our population must have failed to be controlled satisfactorily by other anti-epileptic drugs. So here we have a sort of an indication of the line of treatment for our population. Our intervention, we need to clearly define our intervention so that someone else can replicate and reproduce exactly what it is that we're trying to do here. With regards to pharmaceuticals, we tend to think this with regards to the strength, its dose, its delivery, its frequency, but we must also be inclusive of adjunctive treatments, any continuation and stopping rules, as well as prescribing conditions, including who. So from the same example, our intervention was defined as cannabidiol oil, oral solution 100 milligrams per milliliter, as adjunctive therapy to standard care, including current anti-epileptic drugs. Further in the document, we get even more information to clearly identify our intervention with regards to being 10 milligrams per kilo per day, being in combination with at least one other anti-epileptic drug, and we have continuation rules as well being clearly specified. Comparator. It's very important within an economic evaluation, and one would not consider it an economic evaluation without considering a comparator. Remembering back to our initial definition of always considering multiple alternatives. In terms of trying to provide indication of what a comparator or what the most appropriate comparator is, the most general definition is the item which is most likely to be substituted or no longer needed because of this particular technology. In our example here, we had a comparator of standard care, and with a bit more information provided that this includes other oral anti-epileptic drugs, as well as non-pharmacotherapy interventions. Identifying the comparator, and especially when we get into sort of seeing how value of a new drug is sort of estimated, because it's always with respect to a comparator, the choice of comparator can be very, very fundamental in determining our overall value proposition. Finally, our outcomes. So here we can see that in an economic evaluation, we must focus on final outcomes. That is health, life years, and health-related quality of life, and inclusive of cost. So here we can see the clinical outcomes from our example may be reduction in seizure frequency and seizure-free days, and global impression of change. Whereas in our economic evaluation, so our CAMA compared to our economic evaluation, our outcomes are quality adjusted life years and cost. In our economic evaluation and our framing of our question, we need to be considerate of our perspective and must be clear on our perspective, because the perspective that we apply in our economic evaluation will alter ultimately what costs and what benefits we include. For example, especially private health sector providers may take an accounting profit approach That is, they're only considered only consideration with revenue with regards to what they'd be reimbursed with and the accounting cost of being able to provide it. However, policymakers, and hopefully to a certain extent, rather care more about the economic net benefit. So what's our economic benefit versus our economic cost? Potentially, depending on the economic evaluation and the purpose of our economic evaluation, we can also use the same sort of consideration when it comes to our patients or healthcare users, as they too will be making decisions with respect to whether or not they're going to continue treatment, for example, and the extent to which they perceive benefits and what the cost is to them. With regards to our outcomes for an economic evaluation, as I said earlier, economic evaluation isn't simply about cutting costs or just adding up the costs. Therefore, we must consider always both the costs as well as the benefits. And even in certain circumstances where we consider things to be equi-effective or equally effective between treatment lines, we must always first consider and evaluate the extent to which they truly are equally effective, and therefore always consider that benefit. In terms of our costs, analysis of costs typically involves 4 stages, a relatively straightforward process, once we have a clear perspective. We identify our relevant resources, we measure those resources and in natural terms, we value those resources based on their price, for example, or the opportunity cost value of the resource, and we estimate our total cost, essentially a price multiplied by quantity effect. Depending on our perspective, there will be alternative costs associated with various agents within our evaluation. For example, with a health sector perspective, we consider the time of health professionals, our suppliers and overheads. From a patient perspective, we can see costs associated with out-of-pocket costs that they have to pay, as well as their time and their time of relatives, including travel. We can also look at productivity losses, so the extent to which that lost time affects their work or their ability to work. And we can also consider other sector. For example, social worker visits, police, sort of security guards, and other sort of assistance as well. Depending on the perspective we've chosen within our economic evaluation, not necessarily all of these costs will be considered. From a societal perspective, we will consider all costs, and we'll take note of specifically within whose budget do these costs occur. But more often than not, we tend to find economic evaluations undertaken for public or private insurers, so for public funding or private funding. And this then can influence what costs that we consider. For example, in Australia, under our public insurance schemes through financing of pharmaceuticals for all Australians, patient time is only partially covered. It's not necessarily covered. And caregiving, especially informal care, is not considered at all. When we go through our costing approaches of identifying relative cost items, we need to, and measuring them, there are 2 typical approaches to this, either a top-down or a bottom-up approach. Our top-down, as the name suggests, takes aggregated costs, which are typically more easily and readily available, and it tries to sort of apportion those out to specific activities. Whereas a bottom-up will estimate the quantity and units of each resource associated with each element of our decision. So an example for that top-down approach may be, very loosely and very arbitrarily example here, that a hospital spends 100 million a year and performs 100 procedures. Therefore, our cost per procedure is $1 million. And we can see quite clearly from this example the extent to which that we lose sensitivity and specificity around our cost estimates and may not be reliable or valid. For example, the same cost under this approach is apportioned for a heart transplant as to a casting a broken arm. On the other hand, a bottom-up approach will try and identify each of our resources associated with treatment, identify the number of resources associated with it, and price each resource up to try and estimate our total cost. Ultimately, when we look at undertaking these analyses and evaluating of them, we recognize that there's a bit of a balancing act between the pros and cons between a top-down or a bottom-up approach. In terms of the benefits of both approaches, the top-down is most likely to have data that's readily available, and it can be relatively simple to apply. Bottom-up provides us a more detailed costing, gives us much more specificity around our estimates and validity, often with regards to our estimates. It's more comprehensive and precise. On the other side, though, however, top-down approaches typically use historical cost data. For example, we'll have to wait until the end of a reporting period before we know what the costs associated with things are. They may not properly forecast, so what we've seen previously historically may not be relevant going forward. From a bottom-up approach, it requires detailed data, can be time-consuming, and often requiring expert knowledge. In practice, and thinking about economic evaluations, I guess we may suggest that we often will approach these from a very pragmatic point of view, recognizing that a decision must be made regardless of the data that we have at hand. And often, therefore, in practicality, we'll balance both the top-down and bottom-up, relying on and using the best available data that we have at the time. For certain sort of cost elements, a bottom-down approach may be all that we will ever be able to achieve. For example, thinking about overhead costs of hospitals or even clinics or facilities associated with delivering treatment may only be able to estimate a cost by taking this bottom-down approach. We can move now a bit more in terms of the benefits that we include within an economic evaluation. And again, we still have the same sort of mantra of identify, measure, and value. But with an economic evaluation in health, primarily our outcome of interest is health. And therefore, we consider this as life years and health-related quality of life. Often, this involves transforming from intermediate outcomes that we observe in clinical trials, such as changing clinical indicators, into the more appropriate or final and relevant outcome for our economic evaluation health. This relies upon a causal link between the intermediate outcome and our final outcome measure, health. So we can think of this in terms of HbA1c or FEV1 as being our clinical indicators, but whilst they're indicative of potential effective treatment, in terms of our decision making, what we are interested in is maximizing health. And therefore, it's the relationship between these clinical indicators and their predictions or their ability to forecast actual health that matters. And this is often where the role of economic models come into play. That is, this is where we can mathematically and computationally look at the evidence and essentially link intermediate outcomes that we may observe within our trials to the final outcomes which decision makers are most interested in. It also allows us to generalize to other settings. So an economic model which takes into consideration various inputs can allow us to modify and adjust those inputs to better reflect the decision-making setting. We can extrapolate beyond trial data timeframe within an economic model. As I noted earlier, our decision wants to take into consideration all consequences of interest and that are relevant and direct to our choice in technology, but our often limited data within our observation period in a trial setting, for example. Our model allows us various ways to extrapolate out to estimate and forecast those likely downstream benefits. It also allows us synthetic head-to-head comparisons. In often what will happen is our clinical trial may not have a comparator which is the most appropriate comparator for our local setting, or more often than not, our economic model will draw together and will allow us to draw together multiple sources of data in order to inform our evaluation. Finally, our economic models, depending on the stage at which we're sort of undertaking our evaluation, can also inform us with regards making informed decisions in the absence of hard data, and even the extent to which more data would benefit our decision, and what data it is that we're most uncertain about in making our decisions. When we look to our health outcomes and our benefits here, it's important that we also value our health. And this is where in economic evaluations, we use utility measures, which are a preference-based assessment of the various states of quality of life. And we incorporate these into a sort of summary measure known as quality adjusted life years. There are variations or a number of variants on quality adjusted life years, including years of health adjusted person years, health adjusted life expectancy, and more specifically, I guess, with regards to a lot of the work that the World Health Organization does, disability adjusted life years. In our quality adjusted life years as our outcome measure, we adjust the years of life lived with an estimate of the value of the quality of the life of those years. So if someone was to live for 1 year in perfect health, we would have a quality adjusted life year of 1. If they're unhealthy, we know that this estimate is somewhere between, is lower than 1. And we'll often anchor out our estimates where dead is equal to 0. It's important when we consider our outcomes within an economic evaluation that we're capturing the value as opposed to just simply the measurement of those health benefits, where value is determined by the benefits sacrificed elsewhere, very much reflective of our opportunity cost. That is, what is someone else willing to give up in order to achieve or acquire what we're providing? And therefore, our valuation requires a trade-off. What we'll do is estimate these utility or these preference rates regarding health-related quality of life. So when we're thinking about how can we derive an estimate of the value of a particular state of life, of health, versus others. The two primary ways we approach this is either through direct measurement or indirect measurement. The direct approach will measure patients' preferences directly, often in a trial setting, but not necessarily. This can be often in the form of a choice question that takes into consideration the specific quality of life that someone is currently in and looks to see how or what they would be willing to trade in order to achieve a better state of health. Much more commonly, however, is our indirect approach, where we have a already predefined description of health states, and then we seek to derive estimates of the value of the different descriptions of health states using a population survey. So our direct valuation approach has advantages in that they're very sensitive and can be very specific to the patients and population of interest. And they can also consider a slightly broader range of quality of life that is specific to the patients. However, there are significant disadvantages with regards to its cost and time intensity, as well as question marks around the generalizability often around the estimates that we derive in these very specific settings. Our indirect method, which comprises of two approaches, two kind of fundamental elements, which is a descriptive system. So this is a way in which we can describe the various states of health from the worst health state possible to the best. And we have an algorithm or a predefined value set for each of these states of health. Therefore, in terms of how we go about estimating the health-related quality of life of our patients, as well as trying to attempt to measure the change in health-related quality of life, we simply ask participants within our trial to complete a descriptive system, which is often in the form of a survey, and we apply these off-the-shelf values to measure and also provide a value of the benefit of the gain in quality of life. This is just a nice reference from Chen going back to 2005, just to ask about what health-related quality of life measure and should we be choosing and using in our clinical trials. I think some of the key points here is that there are multiple surveys available for measuring and attempting to value health-related quality of life. And it's imperative that we take a structured approach to thinking about, well, which health-related quality of life instrument are we going to be using to try and measure and estimate this gain in quality of life. What we do then is we try to capture the quality of life, so how well and what state of health are people living, with the quantity of life that they are living. and we combine these into what's called the quality adjusted life year. This allows us to look at not only medicines and various technologies which improve the health-related quality of life of patients and populations, but also increasing in life expectancy. It also allows us and enables us to consider health benefits of very different and dispersed populations and different treatments. So for example, we can, by standardizing our description and our measure and value of health, we're able to consider and compare cancer patients, for example, or the journey of health for a cancer patient versus someone such as arthritis, which are likely to have very different sort of journeys with regards to health. Finally, we put this together to try and estimate our value for money, a fundamental question. Should we be investing in treatment A or treatment B? We do this primarily with what's called an incremental cost effectiveness ratio, where we look at the cost of our intervention, our new technology, our new pharmaceutical intervention, versus our current standard of care or our usual care. And we divide this by the difference between the benefits associated with our new intervention, new technology, and the benefits of our comparator. As this gives us a ratio as our result, we can then think of our estimate finally, or our final value, laying within one of 4 quadrants. On our x-axis, we have our change in effect, our change in benefits, so where we have positive, increasing benefits associated with our new intervention, our new technology, our new drug, or those where we're seeing lesser value in terms of benefits. On our y-axis, we have our change in cost, or our difference in cost between our intervention and our comparator. We're going up from our origin, we're having greater cost than our current usual care, or if we're falling, going net minus, we're having cost savings, which is cheaper than our current standard of care. If our new technology is in what we can call our top left quadrant, we know that our new technology is less effective and costs more money than our current standard of care. We can easily suggest that this is a never adopt, an easy solution. It's both less effective and more costly. So we would never suggest or recommend after their academic evaluation of implementing that new technology. Opposite there in our bottom right-hand quadrant is obviously where we'd like to see, but very difficult to achieve, which is our new technology, our new intervention is more effective and provides cost savings overall in our health system or to our funders or our decision maker. We can easily, again, suggest that this is an easy decision for decision makers to make, and we suggest that it may be dominant, that if we ever have an intervention in this quadrant, we should always do it. More often than not, however, we find our technologies, our new interventions, falling in this top right-hand quadrant, where although we've provided more benefit or more gain from this new technology, it comes at some increased cost. This is where we think in terms of our decision making around a cost effectiveness threshold. That is, if at any stage it falls in this bottom right-hand quadrant, of course we should accept. But for those that cost us more and provide us more benefit, we need to consider at what point do we consider the marginal gain in our benefits to be worth the marginal increase in our costs. So our investment decision needs to consider our willingness to pay for the extra unit of benefit. If our change in cost relative to the change in benefit is less than what we're willing to pay for it, then we should adopt or implement our new technology. It's very important, however, to consider that no true single threshold exists for deciding whether or not an ISA is acceptable. Through the literature, we can find a range of estimates about at what point are we willing to accept and willing to pay for a new technology and the health gains associated with it. A relatively new approach to estimating this threshold value is what's called the opportunity cost. So we can look at what's currently funded and provided and estimate our our likely return on investment of our current portfolio of investments in healthcare. In Australia, this was done about 3 years ago. In the UK, about 7 years ago, and for a number of other countries coming online. In Australia, it turned out that the opportunity cost threshold would be about 35,000 per quality adjusted life year gained. However, when we consider PBAC in terms of retrospectively looking at the funding decisions that have been made in Australia regarding new pharmaceuticals, we can see that the threshold appears to be more like 45 to 65,000 Australian dollars per quality adjusted life year, which is relatively similar to the explicit threshold that NICE in the UK suggest when they are making their decision. In the literature with regards to the United States of America, there is no set threshold, but we see a sort of growing evidence to suggest that 50 to 100,000 per quality adjusted life year, 50 to 100,000 US is where their threshold may be. From the World Health Organization, we have some dated and often misquoted and misunderstood sort of guidance with regards to what the threshold should be, but they suggest, and dependent on the local country, about a value of 1 to 3 times the gross domestic product of the country per person. In Australia, this would be about 150,000 per quality adjusted life year, which is far greater than what we see in decision making and more than what's perhaps suggested is our true opportunity cost, which we should be aiming for. One of the difficulties when we look at our result and when we want to put our result back together again and interpret is that it's a point estimate, and that a point estimate can overly convey confidence in our estimate. However, when we're looking at our economic evaluation, the sources of data that we have at hand, as well as the need and often number of steps that are involved in terms of trying to translate clinical indicators from short-term time horizons into health gains over long time horizons, there's significant and substantial uncertainty associated with this. What's a lot more common practice and a lot more in terms of what we as health economists try to achieve is to try and present some sort of characterization of the uncertainty associated with it. We can do this in either one-way sensitivity analyses, where we can test, well, what if one parameter in our economic evaluation was higher or lower? What would that mean in terms of our decision to implement or not? But we can also do what's called a probabilistic sensitivity analysis, where we look at all uncertainty in our input parameters of our economic model and re-sample, if you like, from each of those known distributions and uncertainty in each of those input parameters to consider the uncertainty in our overall estimates and results. So instead of having a single point estimate, we have a large iteration of estimates, and therefore a 95% credible interval around what our likely estimate of the true value is. Some of the limitations of economic evaluations. Economic evaluations typically do not consider equity. That is, they come from a perspective of efficiency, and therefore decision-making criteria regarding equity, who receives the benefits, is often not considered. They're heavily limited by the data and the quality of the data which they rely upon. They're very data-intensive, data-hungry, and it's the quality of that data in which we need to consider at each step. We need to enter into our economic evaluations with a critical mindset with regards to the limitations that we have. Finally, there is potential for substantial bias by the analyst in determining what is actually included or excluded in our evaluation. There is a constant and ever-growing need for transparency in our evaluations that we provide and the advice that we give. I've just got a few, I've got about 5 minutes from what I can see here. So I'll just try and go through a few sort of key insights around the broad themes of our discussion today around economic evaluation, design, performing, and then in evaluating. I think just to quickly get off the bat, that there are probably 3 key approaches in our economic evaluations. We can do them in a pre-modeling phase. So this is before any clinical trial has actually been undertaken. And we can do this to try and estimate the potential value and the potential market of new technologies and new drugs. The focus in terms of what we're looking for in that type of analysis will often then be in terms of, well, what data do we need to collect? Where are the holes and the gaps that we currently have in terms of if we were to undertake an economic evaluation? And we can inform clinical trial size design as well. We can also undertake our economic evaluations alongside a trial, but we need to be mindful that this is only applicable where all consequences can be observed within the trial follow-up period. We also need to be mindful that the quality of life data collected within the trial can be used in the economic evaluation. So for example, patients with dementia or for pediatric populations who aren't able to express or complete and fill in a survey with regards to their quality of life. Finally, our economic evaluations can also be done and are typically done post the pivotal clinical trial stage. So more often than not, a large international clinical trial is being conducted for a new pharmaceutical. This is our evidence base, if you like, and then we're looking to adapt and adopt and generalize those findings to our local decision-making context. When we're looking to design our economic evaluation, the key thing to feature and the key feature and the function that we need to focus on is our value proposition. So that is, we must consider both our health benefits and our costs, but we need to make sure that in our economic evaluation and in our economic model, we're expressing and capturing them. That is to suggest if a drug treatment profile has a greater tolerance or a greater safety profile, we need to be making sure that we're capturing, for example, adverse events within our potential sources of benefits. I would also suggest that when we go through this value proposition stage, that face validity is critical. It's imperative that we're able to take a step back, understand what it is that's coming through in our economic evaluation and our model, and that meets the clinical reality of what we'd expect. Here's a quick design checklist when we're looking at undertaking economic evaluations. Thinking through, again, costs, benefits, and how we're going to evaluate. How are we able to estimate the change in our resources? How are we going to estimate our change in patient health-related quality of life or life expectancy? Are we able to measure them within the observation period of a trial, or do we require a model? And what's the quality of our data that will underpin our estimates? Very briefly, with regards to performing economic evaluations, we often are faced with the ideal of what we'd love to be able to do within an economic evaluation and the reality of the data that we have at hand. We'll always have data limitations. It's the economist who understands that a decision needs to be made regardless of the quality of our data. But it means that we need to be critical in assessing the quality of the data that we have. I'd just like to take a little step here in terms of some of the tools available in terms of how we might undertake this, and just provide you the top link here, which is to the ISPOR website, the resources and good practices for outcome research, a fantastic sort of available resource for ISPOR members. In terms of evaluation, there are a number of tools available. The first was the Drummond checklist, 10-point checklist, further updated from ISPOR with regards to the CHEERS checklist. I probably am running out a bit of time to go through each of these in depth, but hopefully you'll have the link there to be able to go through and find them for yourself. So I guess just in summary, when we're looking at an evaluation, it's the quality of evidence, and therefore we need to always be critically assess and critically evaluate the level of data and the quality of data that we have. We always need to think about the access to our computational analysis. What data do we have access to? Are we being able to undertake this in both face validity, critical content validity, as well as just computational validity? And finally, how well is our uncertainty being identified, characterized, and presented, especially to our decision makers who are ultimately left making the decision? I've got my website, my email address here for further questions. And thank you very much. I try to rush through there in the end, so no doubt, please send through any questions that you may have.
Yeah, thank you very much. I'm very thankful. It's time to delegates, time to interact with Joshua Byrons. Yeah, participants. So if you're unable to interact directly, you can put your questions in chat box, or you can open your video and you can interact with Joshua. So can you stop share screen?
I can. There we are.
Yes.
And I'll turn my video off.
Now you are looking handsome.
Thank you very much.
Yeah, Joshua, please, please, Joshua. Yeah, there is question asked by Pujita. How to measure the QALY for new drugs in clinical trials? Yeah, you can see question in chat box.
Sorry, my connection might just be failing me. I'll just stop sharing my video.
Yeah, delegates. Nice, ready. What do you suggest?
I have trouble with my audio, but I found a question that's come through in the chat line, which is just how to measure quality for new drugs in clinical trials. Absolutely. So there's ultimately two approaches within our clinical trial, and the primary one is to consider whether or not within our clinical trial our observation period is going to be able to pick up all the benefits or improvements in quality of life that we expect. If that's the case, then what we can do is use our questionnaires, our descriptives, our multi-attribute utility instruments like the EQ5D, and we can ask these questionnaires to both our control group as well as our intervention group within our clinical trial, and we'll do that at baseline as well as at follow-up. That will then be able to provide our estimates for our quality adjusted life years, because we'll have the time that they're on treatment and within our observation period, and we'll also have the scores at the baseline and our follow-up period in terms of quality of life health scores to be able to estimate our qualities for our two groups, and then we can compare between groups within our clinical trial. Often, however, our clinical trial may be relying on a clinical outcome measure. So as I said, for example, HbA1c. So if within our trial we only have, say, 24 weeks or 26 weeks of data with observation follow-up period, and our primary outcome is only on HbA1c, it may be very unlikely that within that short time horizon we're able to capture all the consequences of improved HbA1c. For example, reductions in amputations, reduction in blindness, or increased life expectancy, for example. And so in those circumstances, more often than not, from our clinical trial, any quality of life estimates that we get may not be actually relevant within our economic evaluation period, in which case we're actually looking for alternative data sources for our health-related quality of life. For example, living with blindness, living with minor or major amputation. And so we may not be able to collect that from within our trial. So within our clinical trial stage, it very much is a question of what's our observation period and are we likely to be able to capture all the consequences within it?
Yeah. Yeah, delegates. Yeah, Shu. Good morning. Yeah, any delegates?
Good morning. Good morning, sir.
Yeah, Rashid.
Good morning, sir.
Yeah, good morning.
Good morning, Professor Josh Benz. I have a question regarding as the topic revolves around health.
Yeah, Rashid, please on your video so that I can see you.
Economics and outcome research. My topic is about how from one another, as all the three topics involve evidence generation, evidence synthesis, and decision making.
Okay, your voice is not clear. Yeah, Rashid, proceed.
I think I can see the question in the chat as well. So the question here is, how can we differentiate between comparative effectiveness research, health technology assessment, and evidence-based medicine from one another? So that's a very good question. And often they share a lot of similarities because of the fact that they are looking at evidence generation sort of evidence synthesis and assessing the quality of that evidence, and in one way or another trying to shape decision making. I guess what I would suggest from a health technology assessment point of view is more often than not that they will include an economic evaluation. So they'll specifically look at the costs, and therefore we're considering the efficiency of the benefits that we can achieve relative to the costs. Evidence-based medicine, for example, I believe is a perfect starting point for economic evaluation, because they come with the same kind of mindset with regards to how we define our populations, making sure we consider both the intervention and our comparator, and making sure we appraise the level of evidence. The difference, however, is that while something can appear very effective, it still may not be economically viable or sustainable or represent good value for money.
Rashid, is it clear?
Thank you, sir. Thank you, sir.
Okay, thank you. Thank you for joining us. Yeah. Any other delegates? Sopna? Yeah, one more question is the types of pharmacoeconomics analysis. In which type of analysis safety is concerned, sir?
So this is a very interesting one. Ideally, we consider and capture safety within our quality adjusted life years, or our summary health outcomes. So if we've got adverse events, for example, or potentially different safety profiles with regards to life expectancy or types of risks of harm, we'll capture that within our summary health outcome measure. It's interesting, I guess, and from an Australian perspective, when we look at how the decision making is made with regards to listing new pharmaceuticals in Australia, we actually separate and almost make this a tiered decision making kind of criteria. The first question being, is it safe? That is, if we cannot overcome the hurdle of safety, it's very often that it will not even pass through to the second hurdle of, is it effective? With the third hurdle then finally being, is it cost effective? So whilst I would suggest, and as a health economist, I would suggest we consider and capture the safety profiles within our summary outcome measures of health. When we look at sort of structured decision-making and reimbursement decisions, safety is often put at the very first hurdle and will not even proceed to an economic evaluation without first clearing that hurdle.
Yeah. As my question for my students is in university, I think it is very famous. After clicking in Google, every day it is showing that can you join in our Griffith University? Every day it's pop-upping me in my Google. So is there any master's, MS in pharmacoeconomics and outcome research, health economics and outcome research? Can you suggest on that, okay, what is the eligibility criteria so that most of delegates are looking for that?
So we currently teach health economics and economic evaluation in healthcare within Masters of Health Services Management and Masters of Public Health programs at Griffith University. That's common in a couple of universities in Australia, although there are 2 universities that I'm aware of in Australia that have more specific Masters of Health Economics or Masters of Economic Evaluation in healthcare. The eligibility criteria in Australia is, I'm not the best person to be placed. I often take more higher degree students, so PhD students. Okay. So that for PhD eligibility in Australia, it is to have a master's already completed with a research component is the eligibility criteria. For master's students in Australia, it's typically that you have an undergraduate degree in a relevant field, that you've shown and demonstrated core competencies in that undergraduate degree. So that's usually a grade point average or you've done well in your undergraduate studies. Currently, of course, with COVID and travel restrictions, there are difficulties with international students visiting and being able to enroll. Yes. However, I know in the new year, that's one of the things that the Australian government is looking very seriously at in terms of being able to establish appropriate protocols to welcome more visitors back to Australia.
Yeah, we hope after 3-4 months after the global vaccinated, I think you may welcome the students. Thank you for information. The Sopna Moparthi is Yeah, tell me.
Very good
Yes,
morning,
from
sir.
Swati. Yeah, please,
Very,
on video.
Okay. Thank you very much.
very
Thanks
good
again.
morning, sir. Sorry for the inconvenience with my voice.
Yeah.
Uh, I have a problem while I'm calculating a utility factor in a pharmacoeconomic analysis, sir.
Please,
So here,
yeah, Joshua, please unmute your mic. Yeah.
Sorry,
sir,
I just missed the question.
I have a problem while I'm calculating a utility factor in a cost utility analysis, sir. Here, when we consider for the assessment of a quality, we need to have an utility factor. But certain local factors like the other comorbid conditions are interrupting the calculating the utility factor. So is there any role of these local factors, or we need to exclude those while calculating utility factor?
I'm having a bit of trouble getting the audio through. Perhaps if you typed the question in the chat box, I could see it a bit easier. I understand it's around estimating quality adjusted life years and the role of local factors. Whilst I wait for the question to pop up in chat, I can suggest that the EQ5D, for example, is an instrument that has been translated into many countries, and many countries have their own valuation set. And when we look at the value of various health states, even though they're described the same in the instrument, when we look at how, for example, populations from Sri Lanka versus Australia versus the UK versus the US or Canada, there are differences in what those populations consider more important when it comes to quality of life. So I was involved only to a small extent to the valuation study, and I knew the person who did the valuation study in Sri Lanka, for example, and that was then compared and contrasted to the EQ5D results in Australia. And so from memory, mobility, for example, in Sri Lanka was much higher valued than mental health. So in Australia, mental health was one of the most dominant factors with regards to quality of life and what people considered most valuable with regards to quality of life. Whereas in the Sri Lankan study, from memory, mobility was one of the highest. But that may not be answering your question just because I missed most of it.
Yeah, thank you, sir. Yeah, anybody?
Very good morning, sir.
Yeah, Manish, welcome.
This is, yeah. Sir, I have a question regarding, is there any role of personalized drug treatment in the cost effectiveness evaluation, sir?
Yeah, absolutely. So I think economic evaluations are serving personalized medicines significantly and substantially. So if we think of a typical drug treatment where we just hand it out to a candidate, a population of candidates, and we can think of, say, 50 or 60% may respond to treatment and therefore go on to get health outcomes. We're paying 100% of that population's drug cost, but only for 50 to 60% of them to go on and have greater health benefits. When we see personalized medicines, in particular around, for example, genetic screening, and then sort of targeting or selecting only people with particular gene expressions for the pharmacotherapy, what we're ultimately doing in our analysis is, instead of giving 100 people drugs for only 50 or 60 to go on and benefit, we're able to target initially those 50 or 60 who are most likely to benefit from treatment. What this does in essence is provide greater value or greater benefit to that particular personalized medicine, because we're able to reduce the costs of ineffective treatment or treatment going on to patients who wouldn't otherwise benefit. So what we see is personalized medicines, for example, having a higher drug cost because they're being able to target and selectively treat those patients most likely to succeed on therapy, and therefore still be or represent good value for money.
Okay,
Thank you. Thank you, Manish. Mahesh, ready? Yeah, Dr. Nagasri Koka. Yes, Swapna, do you have a question?
Sir, sir, in order to assess the patient, the factors in cost effectiveness, there is a variation in the patient related factors, sir.
I'm sorry.
So there is a problem with the assessment of patient reported outcomes, which are variating, sir, in case of cost effective analysis. Like example, we take the pain, it's having several grades. In order to do the cost effective analysis, which grade we need to consider for that, sir?
So you might have to repeat the question. I missed the first half. Is about pain?
Sir, in case of cost effective analysis, sometimes we consider as a patient reported outcomes as a measure for the cost effective analysis. Example, if we take as a pain, so there is not only a single grade of the pain the patient may suffer. There are several grades of the pain the patient is suffering. So in order to do the cost effective analysis in terms of pain, how to do and how to consider it as, sir?
Sure. So it's true. And I've focused my presentation very much on quality adjusted life years as being a summary health outcome measure. And I guess from a health economic point of view, that's what we really want to have is a universal measure so that we can compare treatments for a range of patients and a range of treatments in a range of settings. Often what we'll still see is cost effectiveness analyses where instead of having a quality adjusted life year or a summary health outcome measure like that as our primary endpoint, we'll still have an intermediate outcome measure or an alternative effectiveness outcome measure, such as pain, which you might be mentioning here. So we could still use pain in terms of our outcome, and we can still look at our two treatments, and we can still consider, well, this is all the costs associated with treatment A, this is all the costs associated with treatment B, and we can compare, well, what was the improvement or change in pain for patients on treatment A versus treatment B, and then we can still compare them over to it so that we can say, well, drug A costs more, but is associated with a reduction in pain, a mean reduction in pain on some sort of scale. So my understanding is pain is very often reported on the visual analog scale with the smiley and unhappy faces, but maybe other methods. And we can see that, well, drug A has a pain score approximately of X versus a pain score in another drug of Y. What we're left with then is a incremental cost per change in pain scale. So we can say, well, this drug A will cost more, but improve pain. The difficulty for decision makers is, well, what does that mean? How do I compare then what you're asking me for, which is a medication for pain, versus somebody who's asking me to reduce HbA1c, or somebody else who's asking me to reduce LDL-C levels, or somebody else who's suggesting that they can improve progression-free survival on cancer. So we have these outcome measures that are very difficult for a centralized decision maker to be able to evaluate. But having said that, if you have a specific budget, or especially within a department, I can think in terms of a hospital department around anesthesiology, this outcome measure may be sufficient or the only outcome that's required from that decision maker to be able to say, well, that outcome is actually what we're after. So improvements on these other scores of health-related quality of life regarding mobility or anxiety and depression, I'm not too worried about. And all I'm looking to actually improve or change is pain. So as long as your outcome measure aligns nicely with your decision maker, then it's fine to use this other effectiveness outcomes like pain, or even a clinical outcome measure like HbA1c, where it's well understood or established. The difficulty is that it perhaps doesn't support another level of decision making, but you'll be able to support some decision making. So it's not I never say don't do it, or never say it's not valuable to do. It's just think about the decision maker you're coming to them and saying, well, it's going to cost a bit more money to change this pain scale. As long as your decision maker is on board with that being a desired outcome and knows that an increase or a change in that pain scale is worth that change in costs, then that's perfectly fine.
Yes, Swapna.
Yeah, I got clarity about that, sir. You explained very clearly.
Today we are very fortunate to have Joshua. We have been communicating to the ISPAR International, the Pharmacoeconomics and Outcome Research, the ISPAR.org have been supporting around 10 years. So we are unable to contact such a personality, like how the pharmacoeconomics is there, what type of studies are there. Really, you are taken to the maximum extent. I hope our delegates are very fortunate to have you, sir.
It's been my pleasure. I've enjoyed this very much, and hopefully in 3 to 4 months we'll be able to meet face to face somewhere.
Two more questions.
Oh, yes, please, please.
Dr. Koka Nagasri is waiting to ask question. Yeah, Nagasri.
Very good morning, sir. My question is there any specific characters to consider a drug into a standard or investigational drug into the study?
Missed that one again. Perhaps if you could repeat or write in the chat.
Okay. Is there any specific characters we have to consider when we consider two drugs into the study? Either it is a control or it is an investigational drug in our study.
No, I'm afraid it hasn't come through again.
No, just video on this.
So, sir, when we consider a control or an investigational drug in an economical study, what are the specific characters we have to consider to choose the drugs?
So I think it's around choice of comparator, choice of control. So if that's the case, I hope, definitely. So often this is one of the biggest challenges we'll see in clinical trials and faced by pharmaceutical companies as well as decision makers. So often when we're thinking about a comparator in a clinical trial, it may be 3 or 4 years, 5 years before it goes before a decision maker. And what's happening all along that time is that usual care can be changing as well. And therefore, what was an appropriate comparator in our clinical trial may not end up being the appropriate comparator when it comes time for our economic evaluation and our decision making. Ideally, or if we can think of a static world, and if the world was to be able to freeze frame, and we could choose a comparator and have confidence in our comparator now will be the most appropriate in the future, the kind of criteria that we look for is what's the most likely alternative treatment that otherwise would have been given. So we can put ourselves in the clinical decision-making context and think about our population of interest and the particular disease and characteristics. We can think about where we're up to in their particular sort of line of treatment. And we can put ourselves in this particular point in time and say, well, if this new technology was not available, what otherwise would have happened? What would have they otherwise received? And if we can answer that question, then it's that which is the most appropriate comparator. So what's most likely to otherwise have been treated or given? And this can be usual care, palliative care. This can be standard care is the kind of term associated with these things. And this can be very, very minimal care. So we can think about cancer sort of treatment, where we're looking at fourth line or third line, often even lines of treatment, where if not for this new line of treatment that's coming on, this new line of pharmacotherapy, the patient would receive palliative care. The patient probably may not receive anything. It could be sometimes last ditch or last chance efforts on chemotherapy, but often it may be support. So literally some home support, some pain relief, and no other care otherwise provided. Sometimes, and it's very difficult when we're thinking about pharmacotherapies, we must also be considerate and knowledgeable, I guess, of other types of medication or other types of treatment available options. So we can think of LDL-C for cholesterol, while statins is very much the mainstay. We can also think about diet and exercise or other interventions that may be prescribed or at least advised upon by medical practitioners. So we need to take only into consideration not just what's the most likely alternative pharmacotherapy, but we must also think more broadly about what other most likely treatments would the patient receive. I hope that answered your question.
Yes, yes. Thank you. Thank you very much. Delegates, it is time to invite one more speaker. The Shu Chun Lee is waiting for us. Thank you, Joshua Byrnes. Very, very thankful to you. Delegates, if you have any more questions, you can mail me, and there is mail ID. I think your registered mail ID is there, so that you can approach Joshua Byrnes. So he will guide us in further anything like pharmacoeconomics outcome research. So thank you, Joshua Byrnes. We're very thankful to you accepting our invitation and came in time, not on time, in time, and waited for us. So surely we'll approach you for means enhance our knowledge and skills and communicating further means like any higher education to my students. Thank you very much, sir. Yeah, Shu really. Yeah, Shu, good morning. Oh, please unmute.
Good morning. Can you hear me?
Yes, Shu, sir. How are you, sir?
Hello.
Yeah, how are you, sir?
Not very good, thank you.
Yeah, we are very thankful. I think you have been waiting for more than 10 minutes. I think you're listening to Joshua's session. Yeah, before that, we are going to read your profile a bit. Let me share screen your profile, read by Pratisha, the PharmD intern.
Thank you, sir.
Yes.
Thank you, sir. This is an honor to invite Professor Shu Ching Lee, Chair Professor and Discipline Convener, Discipline of Pharmacy and Experimental Pharmacology, the University of Newcastle, Australia. Sir has worked as an academic at the National University of Singapore and as Acting Director and Deputy Director, Pharmaceutical Evaluation Section of Pharmaceutical Benefits Branch, Commonwealth Department of Health and Aging in Canberra. Professor Lee also served as a visiting specialist and consultant to the Health Sciences Authority, Singapore. Professor Lee was among the few pioneers that put the principles of pharmacoeconomic evaluations into practice for regulatory affairs and has been involved in the implementations of the first versions of the Australian pharmacoeconomic guidelines. He has published more than 250 peer-reviewed articles and conferences abstracts on the subject. Served as a director on the ISPAT board of directors from 2006 to 2008. Sir worked as a visiting professor for various pharmacy colleges in Singapore, China, and Thailand. Sir has been involved with research in clinical pharmacy and more than 20 years of experience. He has a teaching experience of 10 years. Sir has a senior pharmacist position as well as chief pharmacist and chief hospital administrators in the Republic of Nauru for a period of 2 years. He did his PhD from Monash University, Bachelor of Pharmacy from South Australian Institute of Technology, Masters of Applied Sciences from South Australian Institute of Technology, postgraduated in Diploma in Management from Daikin University. He did his distance education in Health Economics from Monash University. I request Sir to take this honor. Thank you, sir.
Yeah. Thank you, Shu, sir. So we are very grateful to read such a personality in front of us, having such an experience.
Thank you. Yeah, thank you for the invitation, and thank you for the introduction. All right, the CV now there's a bit.
It's a wonderful
because
now having such a professional expert, professional experience, which is going to share it. Not only in this session, we are planning to have further interaction in future. So yeah, now you can share your PPT and please continue the session. Please share your PPT. Yes. Yeah, you can continue, sir.
Yeah, just check now. Okay, I just want to make sure I can see it, right? Because I can't see the thing myself. Just you know, I want to.
You have shared your screen.
Yeah, okay. I can start now. Okay.
Yeah, go ahead.
I think it's now good morning in India, but
Yes,
it's afternoon in Australia at the moment, right?
Yeah.
So, I'm asked to give a topic to talking about what are the practical issues in performing pharmacoeconomics and outcome research, right? So, I've been working in the field for more than now, from 1993 until now, so about 20 odd years, probably among the first batch of people doing these things in Australia and probably in the world. So that I also have been dealing with various countries in the Asian Pacific area. So I can share some of my experience of what I have seen as the issues about implementing and performing pharmacoeconomics and outcomes research in the Asian Pacific region, especially in countries where the discipline is developing, because I've started basically helping the Singapore government and Hong Kong government, different government to start the unit to run this thing for the government also, right? So I will start my presentation with a very quick overview of what are pharmacoeconomics and outcome research. Why I did so? Because I will highlight some of the factors that are important in the different area, so that I will be able to raise very briefly what are the issues when you are performing those type of researches and what we will encounter. I think the former speaker have talked about some of those things. If I may be able to elaborate a bit more, and then I'll welcome you at the end to ask any questions, and I will try to answer them. Okay, so the first of all is I will give a very brief history of what is pharmacoeconomics and outcome research. I think the former speaker have talked about what are the thing about. Really, when we think about what is pharmacoeconomics, when you come around, what's pharmacoeconomics is the first question you ask yourself. It's really a hybrid science developed in the 1970s, 80s. It incorporates health economics, disease analysis, evidence-based medicine, but also other areas just like econometrics, also psychometrics and so forth. So in a way, it's a hybrid science. It's not really it's not really just health economics. It's more than just economics, because health economics can have many different branches. Okay, so why do we have to develop this one? It's really a response to the increased need of accountability during the age of cost containment in healthcare. Why does this really happen? Is that in the 1960s and 1970s, there's a boom in the health service. A lot of things are being introduced, and there's a lot of what you call new surface, new type of drugs are being introduced. And so suddenly, every country find that they really are looking at some issue in the long term, is that whether they can afford to provide this type of health care to the citizens or not, right? This is exemplified by one of the study which done in 1994 by Bobadilla and the others, which quote very, very nicely is that what are the healthcare problems facing all the country is really a finance problem. What the group say is that no country in the world can provide health services to meet all the possible needs of the population. right? So this is a fact that we, no matter how wealthy we are as a nation, we will not be able to provide all the service need for the nation, right? You can see now, quite interesting, now you can see that during the COVID-19 pandemic, even now, most countries, we cannot even provide for the emergency need of the country. So in the way that we really see how big the problem it really is, right? So actually, when does this term first appear? The term pharmacoeconomics and outcome research actually was first used in a forum, in a pharmacist forum in 1986 by Raymond Townsend, Dr. Raymond Townsend from Upjohn Company. Upjohn is no longer a company now because it's being merged with other company, right? So what the Raymond Townsend talked about in 1987 is that it's a description and analysis of the course of drug treatment to healthcare system and society. So really, he's talking about the course of therapy, right? And then he's not very specific. So a more specific, what you call definition, was provided by Dr. Lau Budman in the American Journal of Hospital Pharmacists in 1989, right? And then what the definition proposed that put forth by Dr. Budman is that research that identifies, measures, and compares the cost and also the consequences of pharmaceutical products and services. So in a way that this actually is much more explicit and tell that we are not only looking at cost, but we only looking at the outcome at the same time for any products and services. So nowadays, what we have become, which is very, what you call most of pharmacists will be quite familiar with now, is that pharmacoeconomics can be summed up as a 5 R's. Previously, I think in the pharmacy school, we all been told that we need to give the right drugs to the right patient, the right dose at the right time. But now we also talk about it has to be the right price, right? Nowadays, in a way that most of the time we're talking about pharmacoeconomics is that people talk about health technology assessment. Really, we can really, what you call is to substitute the drug by technology, any right health technology, and then it's the same thing. So basically, now what we're looking at is that we incorporate another one about the price there to be important consideration, right? So the whole thing, what are the objective of the thing is that very simple thing is that if we look at the macro level, it's only have 3 basic things pharmacoeconomics analysis is going to do is to improve individual public health through improved rational decision making, right? We really want to emphasize is rational decision making because later on I'll tell that what it has done about decision making, but also by how to do it is by determining the relative values among alternative therapies or alternative treatments which are available. And finally, what's more important to allow this one is that to improve system resource allocation, right? Because we have only limited resources, we have to improve how to rationally, what you call allocate the resources to the area which get the best outcomes. Okay, so after we talk about what is pharmacoeconomy, another question we always ask is what is research, outcomes research, right? And then outcome research actually is really a scientific study of the outcomes of diverse therapy used for a particular disease, condition, and illness. In a way that when you talk about it, when does it start? Actually, it has started long time ago because even every drug treatment, every medical treatment, we are interested in the outcome. So in a way that you really want to chase it, is really can say that we are looking at outcome research from time immemorial. But the whole thing, for the things for our intent and purpose, we start to look at things when we look at the different outcomes, probably since 1993. Outcomes research now are broadly defined as the studies that identify, measure, and evaluate the end results of any health service in general. So basically, we refer you to this article, which published in Clinical Therapeutics in 1993 by Cosma and other researchers. What you're talking about is a conceptual model of outcome research, which is talking about the ECHO model. Most of you might have already done it. It's really talking about economic, clinical, and the humanistic outcome, right? So these are nowadays, instead of looking just at the clinical outcome, we're also looking at the humanistic outcome and economic outcome. So in a way that it ties in very nicely about pharmacoeconomic evaluation. So in a way that's why most of the time is called health economic and outcomes research. Right. So when you think about how does it, the three type of the outcomes, how does it relate back to the normal thing we use in pharmacy when we talk about patients? Really, when we talk about outcomes in clinical medicine, there's actually 6 types of outcomes. We talk about death, we talk about disability, we talk about disease, we talk about dissatisfaction, we talk about discomfort, and also we talk about dollars, right? And then when you really look at that, the first 3 are actually related to the clinical outcome, right? The next 2 is the humanistic outcome. And then the last one is economic outcome. So when we look at this thing, really it encapsulates what we want to measure holistically about the treatment effects in any patient. Right. And then very quickly talk about what type of what you call outcome research, economic evaluation study are available. Anyway, if we really think about it, which are commonly used, we can put down into 6 types, right? The first 2 types are the partial one, cause of illness study, cause consequence study. And then the cause consequence study normally is very seldomly done nowadays because it doesn't tell us a lot of information. Cause of illness are more done for public health issues about what disease epidemiology are more important. The other one which we commonly done in pharmacoeconomic evaluation are the CMA, the CEA, and the COA. Cost benefit analysis are done more for program, healthcare program, and other issues, right? So these are the things which commonly observed in the literature and also being conducted for economic evaluations. Okay, so what are the, again, very quickly, what do they really measure, right? You can see that CMA is really assumed that the benefits assume that all the outcomes are identical. The other 3 really are measuring both quantity and quality of life. But the thing is, how do they measure it? One are some of them for CA is explicit in natural or physical units, and why COA normally is talk about healthy year, example, Collins or Dallas, and CPA is all in monetary terms, right? So these are the basic thing. And what I think we all know about it, so just a quick revision, is that by doing economic evaluation, what we're trying to do is that we want to produce a matrix called the incremental cost effective ratio, right? Which is basically the difference in healthcare costs divided by difference in the outcomes. So what I'm talking about is that we try to quantify what the additional cost to achieve one additional outcome. And then if we done for all the drugs available, we'll be able to compare and rank different alternatives and see which one actually will be more good value for money. Okay, I think this again, a table we see, once you put that one, we'll be able to put them in the matrix there, cost and outcome, and then compare whether we should accept the drug or not accept the drug. In the 2 areas where we are put the red line is that on the red line, one the quadrant there is talk about new treatment, inferior, showing that it's more costly and actually has less outcome, showing the way that you will never accept it. And for the other side, when the drug is cheaper and better outcome, you will always accept it. So these are the 2 areas which they call the no-brainer. But the whole thing for these 2 areas, especially the cheaper drug and better outcome, throughout my professional life, I haven't seen any drug in that category. But what are more important is that what are the areas the drug are better, but they produce more costly. So these are the areas that we talk about later, about how to decide on the threshold. These are some of the issues which you will encounter when you try to perform economic outcome and evaluations. Okay, so when we really think about it, economic evaluation is basically talking about input, which is the cost, direct and indirect, put into the healthcare system and compare it with the outcomes, which can be humanistic, clinical, or economic. And then the ultimate objective is really to improve the efficiency of the system, right? So this is really the macro lead well, you think about it. So when we talk about economic evaluation, is to make use to improve what you call rational decision. Really, what it had done is that previously, when you look at drugs, if you don't go through the process of evaluation, you go it very emotionally logical, but you go from a very unstructured type of decision making. So at the moment, what we are economic evaluation is provide information to allow the decision maker to make the informed and structured outcome decision making. So this is the major thing talking about. And then what are the things we're talking about, which are very important in economic evaluation, is the 3 E's. One is the efficacy, and then efficacy is the results we've seen in the clinical study. And then we want it to be translated into effectiveness, which is the outcome we see when the drug is or the technology is applied in the whole population. And then finally, what we see is that how can this improve the efficiency of healthcare delivery? So in a way that these are the 3 level economic evaluation is trying to achieve. Okay, so talking so far is that what are being used for nowadays? I think you all should know now is that they are oftentimes used quite a lot in the reimbursement decision, whether any company or any government will use the public fund to pay for a drug, or any insurance company will pay for certain type of treatment, right? And then its government is also used for price negotiation, right? For example, we look at the drug, the price offered by a company, and then they look at the results, and then they can base on those results, ICR ratio, and also to negotiate a better price or whatever, okay? And then formulary decision, again, formulary decision can be at the national level or even at the hospital level. And then the data can also help in the development of clinical guidelines for treatment. And again, more importantly is the information from economic evaluation can provide very useful information when you communicate to prescriber how to use a drug properly. Okay, so I've been involved in the guideline, so I can say that a lot of countries nowadays have the economic guideline. So on the left-hand side is the first guideline when they published in 1992, when I started at the Common Development Health, and then we do it. And now there's got through many what you call versions now. And if you are interested, you go to the Australian PPAC website, and you'll be able to download the guideline, have a look, and what the latest version look like. But basically, each version is become a more detailed or refining or more specific or explicit description of what they need for the evaluation. The thing now, so in a way that worldwide, just what we say, nowadays, economic evaluation or cost-effective evaluation has now been considered as a 4th hurdle for any company or any drug to enter into the healthcare arena. So the first one we talk about is that a drug has to be efficacious. It has to have produced effect. If it's useless, no one will use it. The second one is safety. If it's efficacious but not safe, we will not use it also. And the third one is quality, right? And I think these are the 3 things that nowadays any company, any country will use it. But nowadays, more and more countries are using the cost effectiveness as the 4th hurdle to allow any drug to be reimbursed or enter into the market, right? And then we talk about what are the examples of some of the different countries about agency using economic evaluation in decision making. I just list some of them. The list is not exhaustive because there are other countries, but I just issue some of the things, and then what year they start to introduce it, implement it. So Australian implement in 1993, and the last one which actually implemented is last year in Japan in 2019. Okay, and then we talk about the available guidelines, the different type of guidelines available. And then this is, again, if you go to the eSport website, you can see that the different guidelines available. When we started, it's only 1 or 2 guidelines, but now the list get longer and longer. So it means that more and more countries are finding it useful to help them to make the decision about drug in reimbursement. Okay, so the whole issue now is that there are so many guidelines. What are the main points and what are the emphasis, similarity? So there's a study done in Hemgren and Arthur in 2001. We talk about what are the main emphasis. Most of the guidelines, we look through all of them, really their main emphasis is about the viewpoint, what are the viewpoint analysis, how to choose comparator, what analysis they will recommend, how to measure cost and benefit, how to deal with discounting, how to deal with uncertainty, and how the results should be presented. So these are really the main emphasis of all the guidelines. And what a similarity is that most of them talk about it, how do they choose the comparator. And then the next similar thing is that what are the criteria, what are the requirements to a good data? And then how do they do discounting, the future cost and benefit, and how do they deal with uncertainty. So these are some of the things, although we say that there's so many guidelines, most of them are talking about very similar type of things here. Right. So as in there, we can now, by now, I think we're all convinced that there's a need for it, and there's a lot of guidelines available. But what are the problem or the barrier that prevent the cost-effective approach be more widely adapted in the healthcare arena then? Right, we look at the thing, really the 2 types of barrier which we will encounter. So now is talking about what are the issues you will see when you will start to implement it. One is the technical and theoretical barrier, right? Those the first type. The second barrier is the political, structure, and logistical barrier. The 2 types are divided into, right? Let's look at the theoretical limitation of the evaluation method, right? So remember we talked about the 4 or 5 types there, right? The consequences really, it only tell you about what the cost and the outcome, which one are better, they never know. They don't provide you any basis. So this is one of the limitations, theoretical. For CMA, although CMA by theory is easier to do, but the whole thing in real life or the clinical situation, there are very few treatment which can produce identical outcomes, very rare, right? Even you say that the same class of drug, they might have difference in the adherence, difference in minor difference in adverse effect, and so forth. So in a way that identical outcomes actually are very, very rare, right? And then most commonly done, we see nowadays are the cost-effective analysis and the COA, right? For these 2, for cost-effective analysis is that it only measures some physical units, and it might not be holistic to what you call to miss out important values for the patient. This is especially important is that a lot of drugs there is that you can see the improvement in the clinical outcome, clinical marker, but the patient actually feel much worse. I think as pharmacists, we all know that if I give an antihypertensive drug to a patient, normally, initially, they'll feel much worse. They won't feel better because they suddenly change their blood pressure, right? So they might feel all the adverse effect of the drug, undesirable effect, and not the benefit. Okay, so these are some of the reasons why sometimes cost-effective analysis may not capture all the patient's preferred outcome. And also, it will be difficult to compare against study, right? I think this one, the former speaker might have spoken it, is that how can I compare an anti-hypertensive treatment compared with a diabetic drug? So in a way that you cannot see which one is better, right? So this is, again, if I cannot see which one is better, I really cannot, how to say that, is random and see that where money should go to first, right? Cost utility, nowadays is most of the study actually recommend you to do a cost utility study, right? Because they're talking about cost per health life quality or what the other metrics to measure. But the problem, I think some of your students have asked not long ago, is about there are difficulty in measuring utility. And also there are problem about instrument and method of evaluation. I'll talk a bit more when we talk about the thing in detail. And then the last one, cost benefit, is that how do you validate the response about, for example, about how to value patient's life if they save about how money. And also, there are a lot of argument between the non-economists whether you can really treat health outcome in purely monetary terms. So these are some of the theoretical type of limitations you encounter. So when you perform it, you might understand this one. When you interpret the results, you have some type of caution. And what are the other problems that can put them in two big part? One is the technical one, is a methodological problem. And the second one, I think some of your students have asked, is that there are lack of local data. And also, in many countries, there are insufficient trained personnel. Actually, even in advanced country, where the things more advanced, they are still limited or sufficient trained personnel to the level that's desirable. And also, other things which are more important is a political issue, which is a bit harder to deal with because it can be the structure of the existing healthcare system, how do they operate, and there are other type of pleasant issues there to think about it. For example, in some country, maybe the pleasant issue is not the whether the drug is cost effective, but whether it's supply or whether they have good quality or not. So this is a different thing. And the third one is the political will, right? So this thing is that how do they want to push it through without damaging a lot of the goodwill of the other stakeholder, which can be the local manufacturer, overseas manufacturer, the medical fraternity, or the others. So these are some of the things there are barriers encountered in many countries. Okay, besides that, we repeat very quickly talk about what are the factors that will important economic valuation. First one is the perspective. We talked about not long about whether broad versus a narrow one. And then comparator, this one, I think the previous speaker have talked a bit, so I will not go through a bit, but if you want, I can talk about a bit more later on. And then the third one is about the measure cost. How should we measure direct, indirect, or intangible cost? What should we include? And outcome-wise, again, outcomes, clinical, humanistic outcome, economic outcome, all of them had their intrinsic problem when you try to measure them and apply them in the economic evaluation. First, let's talk about perspective, right? So when we talk about perspective, you can go from societal to payer to provider and to patient. Really is, again, the 5 P's of the payer. You can from the payer, provider, patient, producer, and society public. So in a way that depending on what question you want to answer, you need to really adjust it accordingly. And also depending on data availability, you need to really think about how can I going to do the evaluation. And then it will affect what data you will correct and what cost you're going to correct. So these are some of the things we need to be very upfront when you try to do any economic evaluation, right? So the next one we talk about is the cost-wise, right? The cost one, we can talk about 3 types, right? The direct one, which is actually very unambiguous, we know, and then but the direct cost can be medical or non-medical. So these are things oftentimes, depending on your perspective, oftentimes they are not measuring the non-medical cost. If you are looking only from the hospital perspective, you might not measure it. But if you measure from the patient's perspective, this one becomes important, right? Indirect cost nowadays is basically the measure as the lost productivity. But the way to measure productivity, again, the different method, whether you use the human capital method or use the efficient method. And then this is all different to provide all different type of outcomes there. And finally, is the intangible cost. And for this one, most of the studies are not actually directly measuring it, but they're talking about if you're using the EQ5D, you measure some of it, but you actually may not measure totally, because normally this can be measured by what we call the contingency method, willingness to pay. But again, there are a lot of other methodological type of issues. So that's why when you look at what you call economic evaluation being published, normally they will not incorporate intangible costs, because we talked about not long ago is that the thing is that different type of culture may look at differently also. So there's always some type of issues there. So let's look at the costing. I think the former speaker talked about the different type of costing, whether you use the macro costing or which is the top down, or the micro costing, which is bottom up. But do they produce similar thing, right? This is the study I actually show you, which published in 2006. Is saying that using one of the bottom up and two of the macro costing method, they produce different results. So in the way that, so the results here, by measuring even just the costing, even direct cost, we can produce different results. If you produce different results, it will affect your final type of what you call the incremental cost effective ratio, and then affect your outcomes totally. So these are things that you can see that different, even we talk about costing, different method can produce different results, right? And then how about, what are the issues? Is that can we transfer data from other country? Sometimes the general consensus is difficult to get estimate from one country to another, because they have different healthcare system, different reimbursement system, and different data capacity. But again, there is some type of exceptions. I published some paper talking about whether cost data can be transferred across country, right? If you're interested, you can, I could be able to contact me. I'll be able to point you to those type of data we publish, that you can actually sometimes can use data from other country and apply, for example, to India, right? So now let's look at how to measure outcomes, because we talk about the first outcome, the economic outcome, we have problem because we cannot really cover all the issues. We have seen all the issues there. How about the other issue? Clinical outcome is more straightforward. Surely, I think we all talk about the clinical outcome. Everyone know about the different level of evidence. From the highest evidence is about meta-analysis, and talk about second level, and talk about properly designed randomized control and so forth down. Right? So in a way that if you follow this one, you should be able to get robust evidence. But is that all? Not really. Oftentimes, when we measure clinical outcome, we are not measuring the final outcome. We are looking at intermediate outcome, right? Maybe we are looking at lower blood sugar level, but is that the final outcome? We look at lower blood pressure, is the final outcome? We really cannot really tell. And also, sometimes is that also we might only measure outcome for clinical outcome for a short period of time, right? Especially in cancer patient, we might only do it for 6 months or 1 year, but how about how long can those outcomes last? In the way that these are some of the issues, are the practical issue, but there are many people trying to provide method or suggestion how to deal with them. So in a way that if you are looking at them, these are the things that you'll be able to find it. All right. Remember, these are the phase one we talk about. We talk about clinical outcome. There are problems, issues we need to be what you call be careful. But more importantly is that we talk about the economic outcome. So we talk about the humanistic outcome now. When we talk about quality of life, actually, quality of life is a multidimensional thing, right? It can be affected by the environment, individual, and also health is only part of it. So in the way that when we talk about general quality of life, they can have an impact on the health-related quality of life. So the whole thing, even you look at the country's condition, for some India may be compared to even to Malaysia, right? Because the environment is different, the individual is different, they have impact in HL, the health-related quality of life. But this is normally not being captured or not even considered in the evaluation. So in a way that there's some type of issue about how you can use data from other countries, all right? So when you talk about what the operational definition about health-related quality of life is really is a multidimensional instrument. You measure more than one aspect of health, and also is focused on the well-being rather than the disease. And it's also has to be patient-rated, right? So in a way that there's a best outcome. But in practice, how do they measure, assess patient quality of life? Normally, it can be by the patient reporting, and sometimes it might be reported by the clinician, and sometimes it's reported by the caregiver. But the the clinician's report outcome will be affected by what he observed from the patient and what he observed from the caregiver. So in a way that you can see that the relationship is that dependent on when they use the measurement, how they get the outcome, humanistic outcome for the study, you can see that the clinician one might be different from the patient's one and also may be different than the caregiver. But again, this will be dependent on all the diseases also. All right. So the next one we talk about what are the other issues. You talk about the way of measuring quality of life, quality of quality in a way that there can be different methods. Can be by interview administer, telephone administer, self-administer, or by surrogate. Surrogate is what we talk about the clinician or the caregiver. So in a way, the different way have their benefit and the strength and weakness. In a way that this also will impact on how you measure the outcome. So in a way that when you compare results or do it, you might understand what are the limitations, so that when you interpret the data, you'll be able to be a bit more cautious when you to interpret the results more meaningfully, right? And then other method to talk about direct method of using measuring quality of life in a way that I think I'm not sure that, because I might miss out whether the former speaker talked about two ways to measure quality of life, health-related quality of life. One is by using the questionnaire, which is EQ5D or SF6D, and the other way is measuring directly, right? Direct measure is either use the rating scale, standard gamble, or the time trade-off, the common one. But you can see here is a paper published in 1982. You can look at one is that look at the fee scale here. You can see that measuring the fee scale, same thing, there's a difference. Rating scale, time trade-off, and standard gamble, right? The rating scale give a higher outcome compared to the other two. Time trade-off actually give the lowest outcome. And then we look at the other end, how about the inter-rater reliability? If we measure by different type of person, do they get outcome? Most of them get about 70. Those are good, but okay, you can see that the difference there. For example, the rating scale get about 98% congruences. The other only about 70. So in a way that they're a bit different. And then we talk about what are the more important to look at down here is that you can look at measuring three type of condition. You use the standard gamble, standard trade-off, time trade-off, or the rating scale. You can see that there are quite a bit difference. For example, especially the last one, right? You can look at the rating scale, the 0.08 for rating scale, the other one have 3.8. So the difference, depending on what condition you are trying to measure, the difference can be very, very large. So in this one, actually can affect your quality of life, your quality measurement tremendously, and give you the totally different type of results. Right. There's another example shown by published data from the International Journal of Technology Assessment and Healthcare in 1996. You can see that I'm using another free instrument, right? I'm not using the direct measurement now, but using free questionnaire, EQ5D, HUI2, and the 15D, the instrument. You can see that about two conditions, the EQ5D give 0.45, but the other two give about 0.86. Basically, it's nearly double what you measured by what you call the EQ5D. And the other two are very similar, they're different conditions. In a way that the difference will be also dependent on what instrument you use. And again, nowadays, we are using more and more EQ5D, but again, you can see the EQ5D may not be all suitable for all the conditions also. Right? This is another study we done talking about how to measure the 4 instruments. Again, it's later done by my research group. We look at 4 instruments we done in the EQ5D, HUI2 and UI3 and SF6D. And then we find that there are differences in the instrument, and then the difference can be clinically important. And then what does it mean is that depending on what instrument you use, it might affect the calculation of incremental cost benefit ratio. And if you affect that, it will affect your final outcome. All right. So other things is that can we use results from other countries really, I think the former speaker have talked about it already, right? One is that there are cultural differences, right? They are also different in cultural belief and value. Why I say so is that I know that in compared to Western country and what you call Asian countries, the way how we look at health, belief, and value is different. For example, I've done a study in Singapore is looking at how does the rheumatoid arthritis affect their quality of life. Some of the old people actually, because they don't want to bother or make too much burden on the younger generation, so they actually underreport the pain and suffering in the score. So in a way that these are the things that we look at differently. The second one, we talk about the method issues. We talk about VAS, rating scale, and all this thing. And the third one we talk about is there's no local data, right? For example, even you UQFID, you need to have data set to actually to convert those into utility. But again, because of cultural difference, method difference, you might not be able to directly use the EQFID and use the other countries' data set to transfer in data in India. So these are the things that we need to be aware of. And then finally, we talk about a bit more about the incremental cost rent ratio. What it's about, I think we talked about it just not long ago. It's a matrix allow us to compare the cost, additional cost to get one additional outcome, right? But really, how does it represent? How was it? What are the problems we encounter, right? Because ICR threshold is that it actually is to produce a threshold for us to decide whether we decided the drug or the treatment is worthwhile the money we pay for, right? For example, we talk about the threshold. I think everyone will know that WHO have produced a guide to CEA in 2003 and recommend 1 to 3 GDP per daily as the threshold, right? Again, NICE also have the threshold. They talk about the 20,000 and about the 30,000 threshold. And then these are the threshold that they start to, if you fall within this type of area, they will say that the drug is available to be reimbursed. If you're outside of more than 30,000, they'll think about it. But recently, NICE have changed it and they gave more. So these are some of the, it's a chart of some of the often quoted threshold, and some of the NICE one are actually the one which has been officially announced it, right? For example, in US, a lot of paper will say that it was 50,000 QALY, but it was basically, when you really look at where they come from, there's a lot of what you call uncertainty. And then Canada, a lot of people quote it is about 20,000 to 100,000 per QALY. But again, this is based on one paper, which theoretically suggests it, but it's not the Canadian one. Again, the Australian, the threshold above 50,000, again, is based on a very, very small study of about 26 studies. And now it's not officially accepted by the government also. Only the one but NICE has been decided, but the thing is that NICE recently have recommend 2 more threshold, which is higher in 2009 and 2017, which actually increase it to about 100,000 to 300,000 for different type of diseases, right? So, and WHO, the 1 of 3 per capita is GDP, but it's not about QALY, it's about DELI. DELI is the disability adjusted life year, which is a different type compared to QALY. But nowadays, a lot of countries, a lot of are using 1 to 3 per capita GDP per QALY as a ballpark figure to measure the threshold. But I have done the thing in 2011 based on the outcome of some recent country to compare what are if you use the 1 to 3 GDP, what does it mean? Really, when we convert them to the monetary value in 2011, you can see that most of the drug will be, if you use that, what you call the WHO recommendation of 1 to 3 GDP per QALY instead of DELI, basically most of the drug will be accepted. So this is the way that's why most of the country nowadays will be very reluctant to use up to three times the GDP. I have actually talked to one of the very senior officers of WHO, and and the person has been the chair of the PBAC, and then she basically agreed with me that the 1 to 3 GDP is wrong. That's not correct. In theory and in practice, it cannot be done. So this is the things that we need to be be careful about. And finally, we talk about the other issue about ISA is that one of the things is that the ISA value can be changed easily by the choice of comparator, right? And then we talk about second issue about the threshold, ISA threshold is the ISA can be problem about how do you measure the cost. For example, whether you use the human capital, willingness to pay, or whether how to use, and then when we even talk about Collie and Daly, both of them have some fundamental measurement conceptual issues there we need to be clarified before we think about it. And again, measurement HRQL, surely there's a lot of issues we talk about. For the benefit of time, I won't go into any detail. I would like you to refer back to talk about. And also, depending on time horizon and discounting, ISA can be totally different. So the whole thing is that ISA itself may not be the only measure you need to decide on the economic evaluation, right? You only give you provide more information, but it should not be the sole information for decision making, right? And so this is a paper which actually published in 2015, which I agree with. My suggestion is that different disease, different drugs might need to have different ISA values. Okay, so in trying to end the thing, not long, I will talk about some of the other issues which are encountered by trying to implement cost-effective analysis in Asian Pacific countries. Right, this is done by I've been involved in this one in 2004, but we've done in a number of countries. But I only show you two of the barrier coded by in 2 countries, one in Singapore. At that time, they talk about what are the major problems implementing it is the lack of critical mass, and also the lack of full appreciation of the importance and application of PE. This among, especially among the government officials, right? And also lack of understanding of incremental cost effective the concept, right? And again, what are more important about the last 3 one is a fear of loss of autonomy in the decision-making process. This is especially among the clinicians, right? You tell me exactly what I can do, you limit my what you call my clinical freedom of practice, right? And again, a lot of government organization, there's a phobia about the data confidentiality, right? They think that what are you using the data for, right? And then the final one is that at that time, there's a relatively poor technical skill because it's relatively new at that time. You don't have that many people with a good skill. All right. And then the second country at that time we talk about region, we talk about Hong Kong. Hong Kong is that they're talking about what are the major issues is that most of the administrator, they are more interested in the financial, short-term financial focus than long-term economic consideration. Because in a lot of time, economic evaluation talk about what you will gain in 5 years. But administrator, they are more interested to see that what are the implications for my budget within this one year and next year, right? This way. And again, same thing about Singapore's lack of appreciation of the importance. And finally, is that there's no legal requirement. So in a way that if it's not required, why do we do it? Okay, so these are the 2 countries I picked up. Why I picked this up? Because this year in 2020, they have another forum being done in Asia, publishing the value and health regional issues. And then 2 of my former PhD students, Dr. Wee and also Professor Law Nan, both of them partake. And then they really find a very similar thing is that what are the different things nowadays is that surely they find out one thing good is that there's increasing need of demand for HTA, but there's still the lack of infrastructure and technical capacity to cope with the increasing demand. And also there are lack of involvement of a broad range of stakeholders, public authority, healthcare provider, and so forth. So in a way that they still don't understand how this can impact on them. So in a way that why I talk about Hong Kong, I think, because some of the issues since 2004 until now is still persistent. So I think that if you try to push it in India, you probably will see the same problem and same issues. Okay, so finally, it's my take-home points now, right? I think I have about 10 minutes or so, is that, remember, what are the objective of thing is that for economic evaluation is really ask two questions. Does a new intervention produce a clinically important improvement relative to conventional intervention, right? Compared to, and secondly is that, does it worth the extra cost? So the first question is that, does it work? And does it produce a value that we think considered to be important? So, in the way that if we put in the layman term is that, first of all, can we afford to pay for it, or are we willing to pay for it? There's two things, right? So these are the two things that we must answer. But to answer this question, how do you really want about is that, does economic evaluation look at other type of objective? Is it congruent with objective of healthcare policy about the equity goal, the clinical, and also the economic goal of the healthcare policy? Because in a way that when we talk about public health, we don't just look at individual patient, we look at population. And equity is an issue that economic evaluation seldom are not taking this into consideration. Okay, with that, I will finish my presentation, and thank you very much for your attention. If there's any question, I'm happy to answer it.
Yeah, thank you, sir. Thank you very much. Wonderful session. Yeah, surely our delegates are interested to ask some questions.
Very good morning, sir. So,
yeah, good morning, Swapna.
I'm fortunate to have as a part of this session because it is all inclusive about the pharmacoeconomics, sir. Really so happy to be a part of this. And my query regarding is in applying a cost utility analysis, whether we applied for acute conditions, sir. Is it possible to apply for acute conditions?
So I did not catch you because the message is not.
Yeah.
I only catch part of her question.
Yes. So no,
can you repeat your question?
Yeah.
Sir, shall we apply this cost utility analysis for acute conditions? Because I heard that we can apply only for the chronic conditions. Because we are in the pandemic now, shall we apply for this pandemic situation? As a cost utility analysis, shall we do this?
It can be applied. I don't think there's any problem. But the thing is that, can you measure the patients enough time? Because normally, in theory, right? For example, if I measure the EQ5D when before treatment and after treatment, you should see an improvement, right? For example, don't talk about the other one, just talk about pneumonia, right? Because normally the COVID-19 causes pneumonia, right? When the patient have pneumonia, when you treat them before and after, they should see the improvement in the EQ5D if you use a thin, or even the rating scale. You'll be able to use that to use CUA. I don't think there's any issue. It's only the things that what instrument you use and whether it's appropriate or not, right? Because there are other instruments that measure different type of, you can measure the pain, you can measure other things. So, but you think about the acute situation, pneumonia, infectious disease. Can I measure utility? Yes, I can. Why not, right? Because for pneumonia, you can see that you have shortness of breath, you cannot move, you got pain in the chest. I can use EQ5D to measure it, or SF6D, and after that, you can see the improvement. I don't think there's any issue.
Sir, okay, that's possible with the pneumonia. But in case of in this COVID-19 situation, the patient who is infected with the COVID-19, it's an acute infection, we can say it as. So the patient may recover within a span of 30 days or whatever we can. So shall we calculate the quality for the patient who are acutely infected with this COVID-19?
No, the COVID-19 one, their more public health is not about, they are not worried about the treatment. Normally, people talking about the, how do you say that, is that unless I have different type of drug treatment to look at the outcome, are more, I think the people in those acute situations, you are more interested to say that, for example, if I got 3 drugs, which I can use to cure or cure the COVID-19 at the moment, you are looking at the clinical outcome more important, because short one, you don't need to spend far too much time, right? Because acute situation, emergency, you don't want to talk about the theoretical thing, right? Practical thing is that, remember, the right drug, right time are more important than what theory, what does it look like to be?
Yes, sir.
Yes, Swapna.
Okay, thank you, sir. So fortunate to have you, sir.
Thank you.
Really. Yeah, my question is, how important is patient reported outcomes in HUR, sir? How important?
Sorry, what did you say?
How important is patient reported outcomes in HUR?
It is important because if you talk about the QALY, you have to be patient reported outcome. Even now, the FDA in US actually accepted patient reported outcome as the way that they start to approve drugs, right? So nowadays, especially when we talk about chronic diseases, for example, in India, diabetes is very high, right? And then the whole thing is that patient report outcome will be important. Otherwise, you give treatment. If I change the blood sugar level, if you have diabetes, you don't know your blood sugar is high. If I give you the treatment, your blood sugar drop, you suddenly will feel very bad.
Exactly.
Right.
Okay, thank you. Yeah, means the delegates. Yeah, Praveen, would you like to ask question?
Yes. Sir, good morning, sir.
Yes.
So nowadays we all know that randomized control trials are goal stool studies, sir. But it has major methodological challenges. That is limited generalizability. So how to overcome it, sir?
Sorry, I cannot hear you because very well, because I only have bit or pieces of what you talk about. I don't get your full question.
Sir, good morning, sir.
Yes.
Sir, randomized control trials are the goal stool studies, sir, nowadays. But it has a major methodological challenge. That is limited generalizability. So how to overcome it, sir?
I still cannot hear you.
Sir, randomized control trials are the goal stool studies, sir. Nowadays.
Can you write down in the chat there? I can look at it because I cannot. I only got the connection is not very good.
Yeah, his question is randomized control trials are there. How important is randomized control trials?
Randomized control trial is a gold standard for the data, right? Still very important because basically one of the mainstay of economic evaluation is evidence-based medicine, right? And RCT is one of the mainstay of supporting evidence-based medicine. So in compared to other study,
yes,
evidence RCT had a stronger what you call level in the hierarchy of evidence.
Okay. Yeah. Anybody else? Yeah. Any delegates interest to ask? Yeah. One more question in chat box. Swati has asked, how to determine one treatment over other using?
I think there's one question here. Sorry, there's one question here about ADR. ADR cost should also be included always because these are two drugs very similar in outcome but different in adverse drug reaction. The cost of treatment should also be included, and also the adverse outcome will also affect the quality of life of the patient, right, in total. And then this will also be affected if you're using the cost utility analysis.
So one more question is there from Swati. How to determine one treatment over other using incremental cost effectiveness ratio?
It really is based on the how to call it, many factors, not just the one of all is the ICER threshold. Different drugs, it depending on how serious. For example, in Australia, if you are is a life-saving drug, they might accept very expensive drug because the number of patients that actually use it are not very large, right? Compared to the, for example, diabetes.
Okay. Okay. Delegates, would like to interact anything? Yeah, Professor Lee, we are very thankful to you. Thank you for even it is, I think it is evening time. Is it 4 p.m. now?
Yep. Okay.
Yeah. Okay. Thank you very much for
Thank you.
the time with us. You have shared wonderful knowledge with us. Surely
Bye-bye.
we are expecting your visiting to our institute in
Thank you.
2021.
Thank you.
Okay. Thank you.
Okay.
Thank
Bye
you.
for now.
Yeah. Thank you. Have a nice day. Yeah. Now it's time to interact. Akruti Madam. S. Apti Chauhar, active and enthusiastic ma'am. He always supports our institution and my students. Yeah, Apti Chauhar, the consultant health economics and outcome research, Gurgaon IQVIA, and co-chair medical device and diagnostic SIG ISPOR. Yeah, now Nagasri will read the profile of Apti Chauhar.
Ma'am professionally trained in health economics outcomes research from the University of Washington, works as manager in health economics outcomes research department in IQVIA. Ma'am holds masters in clinical research from Franklin University, UK. MA in economics from Mahatma Jyotiba Phule, Rohingya University, and is a PhD scholar. He lectures on HTA at various academic institutions. Earlier, ma'am has worked in healthcare technologies for 6 years, where she has represented India at WHO Global Forums and Medical Devices and ISPOR at international forums. Ma'am is a Cochrane member as well. Recently, ma'am was honored by being nominated for co-chair position for the Medical Devices project in the Medical Devices and Diagnostics Special Interest Groups in the International Society for Pharmacoeconomics and Outcomes Research. Authorship and publication contributed as expert in 16 national publications by Ministry of Health and Family Welfare, Government of India, related to medical devices, a conference paper deliveries, including ISPOR. Technology research for conducting HTA fellowship in Training Institute India, including India and India, mentor participant in HTA projects. Thank you.
Okay, thank you, Nagasri. Being family intern, you have contributed a lot in this conference. It's time to talk to our or I can say she's a madam is a guest speaker. Whenever I asked, immediately she will accept our invitation. Really, we are thankful, madam. I know how much busy you are in corporate sector, working in IQA, spending with us. Really, we are very fortunate too, madam. So without delaying, please share your PPT. I will stop share screen.
Thank you, Rao. Let me share my screen. Let me know when you can see my screen.
Yeah, I think you are sharing now. Yes, you have shared.
Yes. So my topic today is the current use and future uses of health economics outcome research for healthcare technology and how we can use it in our decision making at different levels of healthcare system, even in the private sector as the public sector. So my focus will be more on the public healthcare sector,
So first of all, what is health economic evaluation? And it is also known as health technology assessment. So I will be talking more about the health technology assessment because it is the common term we have started using, but nowadays it has been converted into health economics outcome research. How it fits in and how to use it. Now, what I will be more talking about the HT around the world, then what are the challenges and issues, and what are the strategic actions has been taken to advance the HT into developing countries, especially in India. So I will be showing you the case studies from India. I hope I'm audible clearly, Rao. Okay. So moving ahead, I earlier professors have covered it all, most of the things, and most of the slides will be on the similar lines. So first of all, I will be talking about the definition, the proper definition of health technology assessment. It is the definition I have taken from the INATA website. INATA is an international organization for health technology assessment, where all the HT agencies has been registered all across the globe, so that we can have a database of a single HT agency at one place. So from there, we have taken the definition, and what definition tells is HT is a multidisciplinary field of policy analysis. It studies the medical, social, ethical, and economic implications from development, diffusion, and use of health technology. So why apart from the social and ethical thing, I have highlighted the economic implications because it's very important and very crucial criteria to be considered while doing any assessment of any health technology, because sometimes the health technology may be socially, feasible. It is ethical to use in a certain scenario, but it may be possible that it is not, economical in our system. So that's why after evaluating all the factors, we need to study the economic implications as well as economic implications of development and its diffusion and its use in a certain way. So any intervention that may be used to promote health, to prevent, diagnose, or treat disease, or for rehabilitation or long term. This includes the pharmaceuticals, devices, procedures, organization systems used in healthcare. So this is the definition of health technology. It could be anything, right from the glasses you are wearing to the anything you are using to promote your health, to have a qualitative life. So the definition of health technology which I have taken is from the World Health Assembly, which has been taken place in WHO. So what is health technologies is any pharmaceutical intervention, procedure, anything which is facilitating your day-to-day life, or you are using it to prevent your any sort of health issues, is health technologies. And medical device is a major subset of health technologies. Why I have highlighted the medical devices here, why I have used this particular slide, because I have a 6 years of experience in medical devices. So what we faced as a challenges while we are promoting any health technology or any product in the market. So pricing concerns, need for evidence of product value have added hurdles to market access beyond registration. So even if a product is available in the market, it is being manufactured, it is being commercialized in the market, even then the people face, the manufacturers face difficulty to have a proper market access in the market, to sell their market in the market, because sometimes different technologies is being utilized by the people just because of their brand name. So that is where the evidence has to come into the notice of the people, that see the evidences are there that this particular technology is also very good as compared to the other available options in the market. So health economics outcome research provides an efficient way of allocating scarce healthcare resources to ensure optimal treatment to patients. So first of all, how we see the development of any product, that we see first the safety, is the product is safe. Then we see is it efficacious. We see these two steps are done while doing the clinical trials. The clinical trials have been conducted just to see the safety and the efficacy of any health technology, may it be pharmaceutical or the medical devices. Then we see, then it got registered and then it get ready for the market. Then we see the budget impact, that if certain healthcare system, the government wants to implement the certain health technology in the market, what will be the budget impact? Then the cost effectiveness to the existing available options in the market. So what will be the effectiveness, the benefits a certain government or the healthcare system will be benefited in terms of the cost. So these two gives you the economic value, and then the effectiveness in the real world, in both in terms of the clinical value and in terms of the costing value. Then we see the market access, the how good is it doing in the market. Second challenge we face in terms of the being question asked at different levels, right from the patient to the policymakers. So the health technology assessment, or we can say health economics outcome research, conducts studies and develop models to quantify differential values for these healthcare technologies. Differential value means that what is the, the extra benefit a certain system is getting, a patient is getting, or the physician is getting, or the payers is getting from using a certain technology as compared to the other available option. There will always be a comparator in the market. There will always be a new product in the market. There will always be a product which has been used from years and years, and there will always be an experimental health technology. So we need to see the differential value between the two, and because there are certain questions which has been asked from right from the patient to the policymaker. So for example, the patient may ask, will this newer health technology improve my survival that I'm going to use? Suppose, for example, a person is going for a bypass surgery. So it has been gone for, stents. So the hospitals are saying that we are going to insert a bare metal stent instead of just a simple stent. So the patient asks, so what is the difference? Is it going to improve my survival? I am going to live more than the the expected years. So these are the questions which they ask. Will the new technology can improve my quality of life? Will by using certain stent, a certain kind of stent, will able to improve my quality of life? If not, then why I'm going to pay extra? So these are the questions they ask. So on the basis of the clinical and the cost effectiveness evaluation, we answer these questions. So other thing could be, why is this health technology so expensive? What is the extra benefit I'm getting? And what is the extra benefit the patient could ask is whether it is improving the quality of life, whether it is improving the survival. So another physicians may ask, show us the performance of the newer health technology as an improvement in primary and secondary outcome. Is this the cost effectiveness option? If suppose a newer technology comes, so physician will also ask the similar question. Again, the payers will ask the similar question. Is this health technology needed? Is it required? Why do I pay for this? I don't require this. So how safe and efficacious is this treatment? So these are some questions which need to be answered while using any new thing. Even if we are replacing certain health technologies with another health technologies. In the perspective of the policymakers, they may ask, can this new health technology provide performance-based pricing? Can you produce an economic analysis? Does this treatment qualify for comparative effectiveness? Can you show us real-world evidence? So these all questions, these are all questions which they ask, and we really need evidence to answer these questions. And how we can do that? The health economics outcome research, or we can say the health technology assessment, is the way we can answer these sort of questions. And we can phrase a question like Professor Josh told, and we can do the economic evaluation like Professor Shui has demonstrated earlier in their presentation. So what is the significance of health economics outcome research? HEOR justifies the differential value of a new product as compared to an existing therapeutic options. Health economics outcome research conducts qualitative studies and develops economic models to quantify the differential value for a product. This can help mitigate some doubts from healthcare stakeholders. So what are the doubts? That what will be the productivity gains, patient outcome benefits, so how much the quality of life could be improved by using a certain health technologies as compared to another one. We in the real life also, if we just take the simple examples, if we drop the pharmaceuticals and the medical devices, if we take the real examples, then we always in a day-to-day basis we do the comparative analysis. Even if we are going to buy the detergent, we see the Surf Excel is better, Ariel is better, or the less expensive Nirma is better. So we always do that sort of differential to quantify the differential value of a certain product. It is now here in economic evaluation. Here we quantify the differential value of health technologies, right? In a very complex way. It has certain statistical analysis we do in the Excels, we do in the software, just to see the clinical effectiveness as well as the cost effectiveness. So it helps to mitigate the doubts that how much it is going to benefit. Is it really useful if we implement in a healthcare system? The questions like this could be answered with this sort of analysis. So we have talked about the significance, we have talked about why we needed health technology assessment, we talked about how it's going to help us in doing the comparative analysis, in doing the economic evaluation, even if we do the budget impact analysis, in which we don't need actual comparator, we just need to see the what will be the budget to implement certain health technologies in a public healthcare system. But what are the components needed to do such study? So here, these are the components we actually use to do certain health technology assessment. First is the clinical effectiveness, in which we do the clinical literature, in which we take the trial data, we take published studies, preferably the randomized control trials, and we do the systematic literature review and meta-analysis. And sometimes nowadays network meta-analysis is very much trending, in which we can compare different sort of interventions with different outcomes. So clinical effectiveness is one part. Then if a certain intervention is really clinically effective, then we can proceed towards the cost effectiveness, which could be the budget impact analysis, which could be cost effectiveness analysis, any type of analysis which just Professor Shu has mentioned in his presentation. So in cost effectiveness analysis, health economic modeling with lifetime cost we do to calculate the societal gain. Next part is suppose technology is very, very clinical effective. Technology is very, very cost effective. Is it legal? Is it ethical to implement in a certain healthcare system? So we also do legal, ethical, regulatory aspects, sort of analysis related to a technology. So I can give you one example that while I was working in the ministry, we have done an analysis on a handheld ultrasound device. So, and handheld ultrasound device, which we have done the meta-analysis, it was found to be similar to the conventional ultrasound, which is a huge machine. Then we have proceeded to the cost effectiveness, that if we implement the handheld ultrasound device for the use of various purposes, then how much it is going to cost or how cost effective it is. So we found that it is very, very cost effective as compared to the conventional ultrasound machine. So it was clinically effective, it was cost effective, but while we were doing the social aspect, the ethical issues related to that particular technology, if we implement it in the public healthcare system, we realize, and we search a lot of data, and we come to know there is an act made by the government, which is a PCPNDT Act, in which it is illegal to get tested the sex of a baby in a womb. So if hand-held ultrasound device could be implemented in India, it will adversely affect the sex ratio in India, which is very poor in certain regions. So then we realized that although it is a clinical effective technology, although it is a cost effective technology, but socially it is not at all good, ethical to implement in a country like India, where the sex ratio is one of the major health issues we can say in the Indian public healthcare system. So this way we can do the health technology assessment. We need to see the 360 angle of certain technology, right from the clinical effectiveness, its feasibility, its cost effectiveness, and then the fourth system is health system integration model. That how we can adopt whether our system is capable enough to adopt certain technology. Is our district hospitals in India or the tertiary hospitals in India is feasible enough? Do we need that technology? Do we have that kind of disease area which where we can implement it? So we need to see sort of all angles of certain technology. What are the goals of the HTA? So the goals of the HTA for most, the first is eliminating services that are lesser effective or lesser cost effective compared to the alternatives. Effective in terms of clinically effectiveness we are talking here. So estimating the reimbursement threshold, like Professor Shu has mentioned, a lot of thresholds in various countries. In India, we don't have really a calculated threshold, but right now we are considering WHO threshold, which is less if the technology is less than GDP is cost effective. So defining insurance packages like the HTAI, and that is a health technology assessment in India, have come up, the Pradhan Mantri PMJY Yojana, so where we have they have defined certain insurance packages for certain interventions. Fourth is selecting priority technologies or services on scientific merit. Like certain technologies are required on an urgent basis, but some are not. Right. So basic technologies we require at like point of care devices, we desperately required at all the sub centers and primary healthcare centers in India. So we see that what technologies we can implement on priority basis rather than going for the advanced level. Do we have basic technologies implemented in system or not? Is there any regular anemia check of the pregnant lady? So we need to do that from the primary level to the tertiary level. Assessing the best choices in public health provisionally. Again, the same thing. The best choices. What are the best choices we can have? If we are having the options for certain technology, more than one options, then what is the best choice in public from the public health perspective? So these are the goals of HTA. What are the types of basic assessment where we can use, how we can use the health technology assessment or health economics outcome research in real scenario? So first and foremost is technology oriented assessments, where these are intended to determine the characteristics or impacts of particular technology. For example, a government agency may want to determine the clinical, economic, social, and impact of population-based cancer screening or cochlear implants or other particular interventions. So this is a technology-oriented assessment where just government want to see that what are the clinical impact, the economical impact of certain technologies if we implement. So, for example, we don't have a mass screening process for the breast cancer. So the government can see what are the screening options available in India. Like we have CBC, breast cancer screening, which the ASHA could do by hand, or the self-assessment we can do. So other handheld devices are available in the market. iBreast is one example. Other conventional screening methods are there, like mammography, but those are available at the tertiary level only. So these are the technologies which we can use. Either we can use, so we can do the technology oriented assessment here, that whether we can go for primary screening, first screening as a point of care devices, where we could use handheld devices, or the patient who got positive from that particular device can go for second screening, like from the mammography or other advanced level screening available at tertiary level. So these are the some kind of technology oriented assessment which we can do. Second assessment is problem oriented assessments, where we can do it focuses on solution and strategies for managing particular problem for which alternative or complementary technologies might be used. So example here are clinicians and providers concerned with the problem of diagnosis of dementia may call for the development of clinical practice guidelines involving some combination or sequence of clinical history. So they can use a combination of certain drugs, and they don't know how to deal with it. So this is a problem. So like COVID-19 was a problem. So government has instantly, with the evidences available, gathered all the evidences and come up with certain strategies that how we can tackle that situation. So COVID-19 is the best example in a real life scenario currently, which I can give you, where the government has come up that how they can, what technology they can use for the screening, first of all, then how they can, uh, project it to the mass screening, how they come up with the, how they can improve the, sorry, how they can improve the screening mechanism, and how what actions should be taken for quarantine certain population which got positive from the COVID. So these are the problem oriented assessments we can also do through this by gathering the evidences. Now next, it could be used as a project oriented assessment. So it focuses on a local placement or use of technology in a particular institution, program, or other designated project. For example, this may arise when a hospital must decide whether or not to purchase a magnetic resonance imaging, right? It's a basic need for a particular hospital only. Everyone is not deciding. For example, primary healthcare center don't need a MRI because district hospital has. But if they have a certain population or a huge number of population where the MRI plays an important role in diagnosing something, that yes, they can think about. But it's not a very good example. But there are certain hospitals in the private sector I could say that where they can, with they can think about that whether they need MRI or not, whether it can improve their businesses or not by adopting or implementing the MRI. Certain research organization like hospitals, they can do the evaluation whether they can, by implementing MRI in their hospital, whether it could increase the research work, whether it can help the general people, some sort of like that. We can do the project oriented assessment as well through this process. So what are the limitations? It's not about the always the good things we can get from the HTA. The HTA also have a certain limitations. So use in reimbursement is limited if reimbursement system are not strong. So if we don't have a strong reimbursement system, in India we don't have that, but in US and UK they have a strong reimbursement system where they can effectively use HTA in deciding the reimbursement package. Use in standard treatment guideline is not wholesome. If too many medical associations bring out STD, also if STDs are changed too quickly. Suppose we have various organizations and everyone is giving their own standard treatment guidelines. So whom to follow? And one step or the another is different from one another. So we can how can you use that in order to decide the clinical effectiveness of even in doing the analysis in HTA? We need to come up with a common standard treatment guideline if you want to do the analysis for HTA, because HTA also takes the treatment mechanism from the statement treatment guidelines. Using HTA will be a challenge. Cost effectiveness results are negative, but clinical efficacy is well established. If suppose that a certain technology has a very good clinical effectiveness, but it's not budget friendly, so it will be a challenge. It should not be a challenge, but it will be a dilemma situation for a certain system. Whosoever is going to implement that technology, then they have to trade off. Like, it is not cost effective though, but it is showing a good clinical effectiveness. So we need to trade off some sort of thing, that whether a certain system or the organization or the institute is going ahead to implement that particular technology. Once HTA results are accepted, review may take few years. So HTA results are, review itself takes much time to do. Uh, it takes certain expertise. Once HTA results are in practice, it is difficult to change the practices on the mere theory. Suppose, for example, once we have implemented certain results into our system, so it will be a difficult task to change after certain period of time just on the mere theory. We need to go back to the HTA, we need to update the results if we want to change the practice. So these are the certain limitations of using HTA. So what are the steps to conduct the HTA? First, we do the systematic literature review. I already told you about the components, the same components we go for the to conduct any assessment. So first we do the systematic review or the meta-analysis, health economic evaluation, legal, ethical, and regulatory aspect we see, and then we see that its feasibility into health system. And then health technology report is generated, which is available mostly to the general people for their knowledge. So I will be giving you a glimpse what are the systematic literature review, what is the health economic evaluation. All the health economic evaluation has been talked much in previous presentations. So I will not take much time on that, but I will tell you the basic steps which we take. Systematic reviews and meta-analysis. So basically, what are the difference between systematic review and the meta-analysis? So systematic review is basically the summary of all the studies, gathered evidences, and it is a qualitative evidences. While in the meta-analysis is a quantitative evidences, where we compile all the quantitative data of all the studies and we get a cumulative figure. What is the process of evidence-based practice? We define a scope, we frame a question, then we frame the keywords, then we do the researching on the different databases. For example, PubMed, Science Direct, Lancet, Cochrane is a database for other systematic literature review, and also the clinical trial data. Then we select the studies, we do the screening, we select the study, and we then pool the studies, and we extract the data, and we analyze the data, and then we present the data. This is a simple process. Although it looks simple, but it's a very tedious task, right? From the defining the scope till the analyzing the data. So these are the different evidences, right from the background information and expert opinion are least required until unless we have meta-analysis data or randomized control data. Randomized control trials are preferably taken for doing any systematic literature review. So these are the hierarchy of the quality of the different types of studies. So background information comes at bottom, then case control studies, case series of the reports, then we have cohort study, then we have randomized control trials. But my friends, randomized control trial is a very, very good study, but we do have other studies which are more good than the randomized control trial, which are critically appraised individuals, articles, critically appraised topics, then systematic reviews, and then meta-analysis. Meta-analysis is at the top of the pyramid because it have, analysis of certain kind of studies pooled at one place. We have checked the quality of these studies, and we have extracted the data. We have done the risk of bias. Risk of bias is used to do the quality check of particular study, and we take good quality studies. So this is the Cochrane library where we get the evidence for healthcare decision making. This is the Cochrane website. You can go and check it out. If few people don't know, this is a very good place to start learning the systematic literature review. These are the free software available to do the meta-analysis. RevMan is a free software, especially for the academic purposes. You can go and download it and start doing the practices. Other available options are EasyMA meta-analysis 5.3. To be honest, I have just used the RevMan 5.3 and not others. There are also other software available, WinBugs and R also, where you can download it free of cost. But for that you need the coding. And in RevMan 5.3, you don't need the coding. It's just the practice, and you can check the Cochrane. They have guidelines how to use the RevMan. So this is how the RevMan looks like. This is how we can start the systematic literature review. This is one example which I have done at the start of my career, the clinical effectiveness of home dialysis compared with the hospital dialysis. This is a systematic literature review I've done long back ago. So this is how the meta-analysis the result looks like. This is one slide I'm showing you, which is known as a forest plot. So meta-analysis result looks like this, right? So this is a forest plot, and you can see here that we have overall effect. This is how the result of many studies combined together we can interpret in this way. So this is a whole lot of the other session to describe what are the types of the studies, how we can extract the data, what are the types of the data. So this is just a glimpse I'm giving you that how you can use the HTA result in the decision making, what are the current and in the future also what you can use. And this is how the components of HTA works. Another is health economic evaluation. So health economic evaluation is a small part of health economics. Health economics is a broader term, while health economic evaluation is a one part of a subset of health economics, where other topics in health economics are the optimal size of the hospitals, optimal payment of physicians, optimal level of co-payment by patients. These are the other topics which we can. So what is economic evaluation? So Drummond is a person who is known as a sort of father in health economic evaluation. So he has given this example. I also have his. I recommend, if you are interested in learning the economic evaluation, go and buy the book written by Drummond on health programs. So it's a very good book which compiles all the glimpse and all the types of the economic evaluation in one book. So I'll recommend go and read that particular book. So he has given the definition of economic evaluation as economic evaluation is the comparative analysis of alternative courses of action in terms of both their cost and their consequences. So my friend, don't see economic evaluation just a thing about the cost, but it also deals with the consequences. So what could be the consequences are? It could be in terms of in mortality, in terms of death, in terms of quality, in terms of Delhi awarded. So there are various types of consequences which we can think about. There are different types of study outcomes which change over the time. So we have already talked a little bit about it in my previous slide, where I've shown you right from the safety till the market access slide. So here we see that while in the clinical trial, so we see whether the certain technology will work. So it is known as the efficacy. If the technology works or not, and how much it works, it shows the efficacy. While in the real world, that health technology comes into the real world, we see the effectiveness. So people generally confuse about the efficacy and the effectiveness. So efficacy and effectiveness are two different world, and they don't both have two different meanings. So efficacy is just to see is it the clinical evidence is efficacious enough, Is it efficacy in order to fulfill the objective for which it has been prepared? So effectiveness is to see in the real world that is it effective in certain population, is it effective in a broad population, and how much it is effective in compared to the other thing. Now, is it worth doing it compared to other things in terms of money, in the same money or with the less money? It is known as the efficiency. So I'll request you all just to don't get confused between these three words: efficacy, effectiveness, and efficiency. These are the three words which had totally different meaning, and you could in the health economics outcome research, you should really know the meaning of these three words. Comparison of economic methods and calculation. This is a slide which I have taken a screenshot of a book from this medical device book is published by the ISPEOR a few years back. So this is in one chapter in health economic evaluation, they have given this table. So I have taken that picture from that book and I've displayed here for you guys. But these are the types of the economic evaluation. These are the basic formulas which we use to calculate sort of method. I hope in the previous presentations we have gone through each and every type of economic methods. This is the discounting math we do for these methods. This is the input in the dollar. In if we want to do in India, then we can use in rupees. This is the output which we expect, the total results. So this is a different type of economic evaluation depending upon your objective, depending upon your research question. So what goal it can give you. These are the advantage, disadvantage of every economic method, and these are the examples. So first is the cost of illness, just to see the cost of any disease in a country. Second is cost minimization analysis. The outcome is just for the net saving of using one technology compared to another. For example, if you are using iPhone and if you are going for another Samsung, so how much cost we can save? That's it. No other outcome. No delay. No no mortality. Nothing. It's just to see how much money we can save. Cost effectiveness analysis is the very the term which is used very much, and most of the research people do a lot of cost effectiveness analysis because it is related. It's not only give you do the analysis in terms of cost, but also the consequences, the health effect we can see. So incremental cost against change in unit of outcome is the result how we express in this particular cost effectiveness analysis. It have the cost of both the technologies. Also, it should have the effect of both the technologies. That's how we can calculate the cost effectiveness analysis, and the ratio of both the things is known as cost effectiveness ratio. Another is cost benefit analysis. It is also in terms of dollars only. Cost utility analysis, then here we see incremental cost against change in unit outcome adjusted by patient preference. For example, compare two cancer treatment and use utility measures, right? So these are the kind of economic methods I hope you had explained in detail in previous presentation. Another is distinguishing characteristics of healthcare intervention. So how can we see what kind of evaluation we need to do? Either we need to do partial evaluation or the full evaluation. This is again a table I have taken from the Drummond book, and this is in his first chapter only. So is there two or more alternatives? So it has divided into no and yes. No, then are both cost and consequences of the alternatives examined? If it is also no, then examines only consequences. That we need to do only partial evaluation, and it describes outcome description only, because it has not involved two or more alternatives. It just only have one health technology. If it does not involve two or more alternatives, but it has input and consequences, then we need to examine only cost. That is also a partial evaluation, but here we just need to give the cost description, right? For partial evaluation, cost outcome description only. Now again, if we have two or more alternatives and we have both the cost and consequences, then we need to, but we don't have, we don't have cost and consequences, then we need to do only the efficacy of or effectiveness evaluation. Then we do not need to do the costing part because we don't have that cost. But we do have both the alternatives. We do have cost and consequences both. Then we need to do the cost analysis. Here we will do full economic evaluation. What should count, what should it be mentioned, and what should it be valued. So in the no also we can see this is how we can do the analysis. Whether first of all we will see whether we have two or more alternatives, it has both the cost and consequences or not. If only examines consequences, then we only do have to evaluate the outcome description only, and we don't need to do the cost description. And if we have only cost, then we need to do cost description only. If we have both the things, then we need to do full fledged health technology, health economic evaluation with, and we need to see what method we need to use, right? So this is the cost analysis template, how we collect the data for the costing. This is again from a chapter from the ISPA book. I can give you the links to the books. You can go and check it out. It's not freely available, but you need to purchase that book, where I have taken this table. So they have very briefly described how much cost, what cost you need to take for certain, to do the health economic evaluation. You can improvise it according to your needs. So this is how we do the, after doing the cost effectiveness analysis, this is how the plane looks like. This is known as the cost effectiveness plane. Suppose after doing the cost effective evaluation, if a certain drugs comes in quadrant 1, like, so in the y-axis see the incremental cost, and x-axis see we can see the incremental effect. So this is the positive. So if we go by the y-axis, this is how the cost of the technology increases. With the x-axis we see the effectiveness. So in this quadrant, the treatment generally is more costly and effective. In this quadrant it is less costly but more effective. So we generally, if technology comes in this quadrant, we no doubt takes it, saying that it is less costly but it is more effective. Now the technology comes in this fourth quadrant, then it is more costly and less effective. So what is the need of taking it? So we dominate it. We don't, we just rule it out. So this plane comes once we do the analysis. There is a lot of statistical analysis goes beyond in the Excel, and this is the last thing we get from the cost effectiveness evaluation, and then we interpret whether the technology is cost effective or not. So this is how it goes. This is the line. Once you understand the economic evaluation, you can understand this. So this is the basic slide which I can show you how we judge the economic evaluation. Suppose we have two technologies, A and B. After doing all the analysis, after doing all the statistical analysis, if the technology A comes here and B comes here, you can say that if this is the coordinates, right? Here we can see the technology is less effective than A, but it is more costly, right? If we see technology A, then we can say the technology is more effective clinically, but less costly. So A is better technology as compared to the clinical effectiveness, also the cost. So if you remember the definition of the Drummond, there you have seen that we need to determine the health technology assessment in terms of its costs and its consequences. So technology A is doing a better job than B, right? So this is how we do the economic evaluation. So here we have completed what are the uses of health technology assessment or the health economics outcome research, what are the components, what are the challenges, what are the significance. Now, in terms, if we come to the use in Indian perspective, this is some case studies I'm showing you from the India. So this is the first HTA compendium published in collaboration with the Ministry of Health and Family Welfare and World Health Organization, where you will find a lot of HTA has been done in a brief manner. This is some HTA used to do the pricing of stents a couple of years back in 2014, where the stent the ministry has done the pricing of stents through health technology assessment and show that what should be the price of a stent and how it should be market. And this is another example. This is in India. We do have health technology assessment in India, which is known as the Secretariat in India, which is a platform for health technology assessment, which is a government body for the health technology assessment. It comes under Department of Health Research. You can go and check this website. Earlier, it was known as Medical Technology Assessment Board, but after a year or so, it has been converted into Health Technology Assessment in India, where you can find certain policy document which has been made on the basis of the health technology assessment. So you can, if you check the website, you can search the outcome report also along with the policy documents. So far, they have done on safety engineered syringes, intraocular lenses for cataract surgery, cervical cancer screening, long-acting reversible contraceptives, hemoglobinometers for anemia screening, where in each of the policy document you will find they have compared these technologies with the available options, and they have done the analysis and have displayed and made the policy document, how it should be implemented, how it could be used. And for the safety engineered syringes, even the Andhra Pradesh government has implemented in their healthcare system, and slowly it has been extending to all across the states of India. Even Punjab has implemented that thing, the safety engineered syringes in their public healthcare system. So these are the screenshots from the Twitter while promoting their. I'm not say promoting, while they were displaying their their achievement in HTA, how they have done the cataract intraocular lenses, HTA of intraocular lenses for cataract surgery. So they have a screenshot of those. You can, I'll recommend you to check their website and to see how they have done those things. These are the letters from Andhra Pradesh, and how they have implemented when and how they have implemented the safety syringes in order to avoid the infections and all sorts of other things which are being happening due to the reusable syringes. So this is another example of HTA on TrueNet, which is a diagnostic device for tuberculosis. TB is a very is a disease which has been there in India from past many years, and how this diagnostic device could help in screening more and more TB people. This is another screenshot. HTIN after certain years, they have also come up with certain evaluations as a compendium of health technology assessment in India. You can check it out that as well. This is another portal. This is a National Healthcare Innovation Portal. So another way of using health economics outcome research in Indian public healthcare system for making the decision is by doing the health technology assessment for innovations. So this will really have the new innovations which are coming up in the market. We can check, and we can see that is there any innovations which is required in Indian public healthcare system in order to having a more robust system by having various innovations for various devices. We can do by gathering the evidences. They do the evaluation of innovations, and then they request the states that this is an innovation on which evidence has been collected and shown a very good results, and they can implement it in their system. So this is how the HTA has been using in India, and you can use it too for your organization if you want to implement certain, or are interested in certain technologies. So this is the institutional framework for assessment of health product, how they do the screening, how they do the health technology assessment, what data and what technology readiness level they adopt the technologies. So this is how they do. They first level screening is done, then how the screening committee selects the and approved by the Ministry of Health and Family Welfare, and then they do the health technology assessment. Either they go for the results then go for the appropriate health technology uptake showcased in the National Best Practice Summit. They do have a annual practice summit where the innovations whose result has been incredible in health technology assessment get the chance to showcase, so that other states can see and can uptake those innovations as per their needs. So this is the uses. How I have shown you some case studies from India just to show you that how the HTA has been used, how they are using, and for the innovations as well in the future as well. So this is it. So thank you for bearing me. Thank you for the inviting. Thank you so much. Any queries?
It's not bearing you, madam. It's very positive to have this much. No, actually, most of healthcare professionals, they don't know what HTA is and what HUR is. And you are making that, we have been screening. Currently, the COVID is making to use CT scan and the MRI scan. So, but we should know what instrument quality, how much quality it is. So, how this health technology assessment will help us to assess how much quality of instrument it is. So, really very informative, madam. And now the most of delegates are interested to ask interact to you. So, yeah, delegates would like to interact, madam.
Good afternoon, madam.
Good afternoon.
Madam, does record linkage system has any role in performance evaluation?
So, sorry, Mahesh, your questions. I can't hear your voice clearly. Can you repeat it again?
Yes, madam. Does record linkage systems has any role in health economic evaluation?
Sorry, which system?
Record linkage.
Record linkage.
I didn't. Recording case. Sorry, Rao, I didn't get what system he is talking about. Can you type, Mahesh, what system
in chat.
you are talking? Pardon?
Mahesh, you put in chat.
Yeah, please, Mahesh, please put in chat.
Means how is healthcare assessment carried out in India, madam? What are the corporate organizations supporting, and what are the? I think you have mentioned about national organization. What are the private organizations or corporate organizations are looking for HTA, madam?
Yeah, so corporate organization mainly do it for the manufacturing companies, right? So in India, so far the corporate has not been much utilized in government sector. So government has their own secretariat, which is Health Technology Assessment in India in Department of Health Research, where they have made their own regional setups like NIRT Chennai. They have made PGI Chandigarh is their regional setup. So they have made the other organization which comes under ICMR or Department of Health Research or Ministry of Health and Family Welfare. Those organizations in different states has been made as a HTA regional bodies. So they are, for now the corporate sector is not pretty much involved in government in doing the HTA, but the corporate is involved in other manufacturing pharmaceutical companies and other medical devices companies in order to provide their services to do the health technology assessment, which is being used in various purposes, like for the submission, nice submission, and other collate the clinical trial data. So there are other various uses in the corporate.
What about, I think in Andhra Pradesh we have a AMT, Andhra Pradesh Meditech Zone. So is there any health technology assessment studies are going on?
Yes, this AMT study is also another regional setup from Department of Health Research. So they also have a division which is doing the health technology assessment. So these all are comes under Ministry of Health and Family Welfare. So they every organization has certain people, a division for doing these sort of analysis.
But whereas government sector is, I think it is limited area, madam. But how the opportunities will come to like our PharmD or some most of healthcare people can gain the opportunity in
so they regular need people. So they need people. They put out the job profile in the websites. So yes, there is a limited opportunity, but there is opportunity. They keep hiring people. They are building their team because India is a developing country in terms of, if we talk about the health technology assessment. So HTIN is not very old. So it's recently been made. So they are also building up their team. So it will take maybe certain more years to, other countries like we see the UK, they have a well-established health technology assessment bodies. The NICE is there. They have databases for doing the analysis. We don't have that. But the HTIN is slowly developing the databases. And now if you go and check their website, they're coming up with the costing databases where they can, easily can have the data. Earlier, one of your students were asking regarding the utility data. We don't have Indian-based utility data. So right now we are dependent upon the other country utility data, or we need to do the primary exercise for that. So PGI Chandigarh is also coming up with that database. So slowly, unless we don't have strong databases for such things which require to do the health technology assessment, it is difficult. So we are moving towards that direction. PGI has already come up with the PGI costing costing database where they have included certain disease and certain interventions. So maybe in few years we can see a lot of databases with the utility, with the costing, and with other things which we require to do the health economic evaluation.
Okay. Thank you, madam. Yeah, delegates. Yeah.
So Mahesh has a question. Does record linkage system has any role? I'm so sorry, Mahesh. I am not aware what is record linkage system. Can you just tell me what is record linkage system?
Yeah, Mahesh.
Is it related to the pharmaceutical industry?
Yes, madam. It is nothing but the data matching, madam. Linking the two records of a particular patient at different times.
Okay.
Yes.
Yes, in the primary study, if we can see, then it can play a role. But I hardly have any knowledge of record linkage system. But yes, you told that is related to the patient, then we can use it. But if we are doing a primary study pertaining to that disease area which involves those patients, then we can definitely use that. But economic evaluation, I say that it needs whole lot of other expertise. You can develop those expertise. You can start doing developing a curriculum which can I can say a module in your courses where you can teach health economic evaluation, or you can start doing the projects. So every master's or the PhD has certain assignment to do in which you can uptake those projects which are related to health economic evaluation. So
okay,
that one thing is there we can do.
Yeah,
okay.
Nagasri is going to ask question.
So any student have any query?
Yeah.
It's not query, just record linkage system. What is record linkage system is when a patient comes to the hospital, we enter patient data into a system, and if the patient comes again and again to the hospital, all the record of the patient will be combined into that system, and all the details is recorded and linked. So it is called recording linkage system.
Okay, great. So that is, yeah, so that is a very nice database you can have for the patient, right? If you can have that database, it plays a very good role in economic evaluation. That is the database I was telling, that we don't have certain databases. So that specific database we need, we will be having the demographics of that particular patient. We will be having, data on their comorbid condition, their improvement condition, whatever disease area he will be in. So we can use that, if at all we can use that in economic evaluation. So we can do the analysis of that data, but along with it, we need the costing data also. But patient data, costing data, utility data, these all play a role, and you can have a patient data. So it's a database which we need to do economic evaluation. So yes, it can play a very beautiful role in economic evaluation.
Yeah, can you suggest me? I think you did the MS in HUR at Cranfield University. What you suggest, madam? How it will help for family students?
What I have done was not on economic evaluation. Hello.
Yeah, it's fine now.
Yeah. So what I have done was not in economic evaluation. So Cranfield, I'm not aware now. They have. Can you mute it? Yeah. So I'm not aware whether they are providing masters in economic evaluation. But in what is happening?
Yeah, I'm unmuted. You joined unnecessarily. Yeah, speak, madam.
Yeah. So you need to check whether they are offering the economic evaluation courses. I think it is creating problem.
You can speak, madam.
Okay. Yeah. So you need to check what courses they are offering. I'm not aware whether they have economic evaluation courses there. So what I have learned through experience. I don't have a degree for that, but I have completed my economic masters in economics from Mahatma Rohilkhand University, that is in Bareilly. That too is not from health economic background. I have done my professional training from University of Washington, that offers with a huge fees, but you can get a scholarship if you want. You can write to them for the scholarship if they can give you. So at that time, I was working in the ministry when I got that scholarship, and I have done that professional training, and through experience, I have learned. So I have not yet completed any degree for that, but I am doing a PhD in that. I have taken that subject. So in that I have also learned more in economic evaluation. So in India, I think Manipal University has started a master's in economic evaluation, where uh, you can have a degree if some student want.
Yeah, whereas earlier speakers and Joshua and the Professor Lee has mentioned widely, globally, and whereas PEO and HUR, really, we are not up to the mark. What they have mentioned in the slides is really, I think we are in budding stage, whereas HUR, PEO, ISPAR has been making a number of regional chapters and student chapters, but even we are coming out and making the things to know only definition level, classification level, but whereas not on practical level and project level. So what you suggest? I think you are also in the part of ISPAR.
Yeah, so I'm also part of SPUR, but I really suggest if you can start the practice, please make, in the last year also, I have given the same suggestion that start doing the projects. So at the end of the masters, if until unless you don't start doing the projects, the students will not learn. So theory is okay, but for doing the projects, you can also add a module in your course, in your masters or the PhD. If you are providing the PhD also, you can add a module of economic evaluation subject or health technology subject, where you can teach them and you can encourage students to uptake a project at least. Like for example, the students who are working in the record linkage system, they can use that particular data and then they can evaluate that thing. So there are various types of economic evaluation. The cost of illness, even the cost of illness, they can do.
Okay.
Yeah.
Any participants? Delegates would like to interact? I think one of Srinivas Reddy Talla has mentioned that most of corporate sectors, they are maintaining some HIMS software, madam. So I think they are securing the data. So in shortly, yes. even our government hospital Guntur also, they have started by using recording the data by using some softwares. So I think our government also planned a health card system. Then obviously, so data will be more and more, patient data will be secure, and we can know what exactly happening in healthcare sector. So, yes. Okay, I think I can conclude. Okay, I'm very thankful to you, madam. All speakers, Joshua Byrons and Professor Lee and Akriti Chauhan. So even Saturday, it's a weekend, but it's a great pleasure you accept our invitation. In future, after COVID 2021, we're going to see you live in our college. So, Chalapur Institute of Pharmaceutical Sciences. We are very thankful to our principal, Professor Ramaran Adinla. So, we have one more session. Devarishi Bhattacharya session is going to start at 2 p.m. shortly. So, thank you very much, madam. I hope, as you mentioned about regarding project, we'll communicate to you by over the phone or by mail. Surely this year means some extent, because whereas international spoke about HUR, really the Professor Lee has mentioned it means some extent PEOR, they have come with a lot of knowledge and practical, and I think he has written so many books also. He has shown guidelines of pharmacoeconomics and outcome research. So ISPAR also, Professor Gupta sir has written, as he made guidelines in India. So means what extent means we have to, by mingling with like your professional people and involving our students, and obviously PUR comes to the means the public sector, and we can utilize the need of that. Okay, thank you very much, madam. Thank you very much. I am ending the session, and we'll join to 2 p.m. sharp.
Thank you for inviting Rao. Thank you so much. Thank you everyone. Thank you every student. I'll encourage you to please take up the project and lead the HK projects in your university. Thank you so much.
Okay, thank you very much, madam. I'm ending the session. We'll come back at 1:45 p.m. Please join the session without miss the session. Devaraj Bhattacharya session is there. Thank you, madam. Thank you for your time.